organized by IAP Kottayam branch. And first session was chaired by Suman sir, and topic was on pneumonia. And this time we are having a case on liver disease. And when we thought about who should be the teacher for that session, there was no other name other than Riaz sir. And Professor A. Riaz sir is a renowned pediatric gastroenterologist. He's an astute clinician and teacher par excellence. He was the professor and head of the Department of Pediatrics at Government Medical College, Kozhikode. And presently, after retirement, he has joined as professor and head of the Department of Pediatrics at KMCT Medical College, Calicut. He is a PG teacher and PG examiner for the last 36 years. And he has more than 50 papers to his credit. And he has authored 2 books, which is well-known, renowned among postgraduates as well as undergraduates, especially that question answer book, which is very useful for most of us for our vivas. I usually refer that book for many of my examinations and whenever I am going for an exam also. So I remember sir as one of the best quiz masters I have seen. In many of the pediatric IAP forums, sir has acted as a good quiz master for many of the IAP postgraduate and UG quiz programs. And I welcome you, sir, to this program, PG Clinic, conducted by IAP Kottayam and ICH Kottayam. And we have our junior resident, Vishnu Narayanan, who is going to present the case towards you, sir. And I think this will be a very fruitful session. I again welcome our darling madam, who is the professor and head of the Department of Pediatrics at GMC Kottayam, Medical College Kottayam. And she is a pillar of support for all of us in the department as well as for all our PGs training programs. She is the backbone of the department now, and is doing the activities in an excellent manner in the department. And UG and PG training programs have been well coordinated by madam now. And I welcome madam to this program. And we have Dr. Joseph Patani, who is the president of Kottayam IAP, who is the pillar of all of the activities of Kottayam IAP nowadays. And in the absence of Preja, who is the secretary, she is having duties. That's why she has not joined the session. I think she will be joining the session in a short while. I take this opportunity again to thank our great visionaries, M. Vijaykumar sir, who is the president of Kerala IAP. And along with him, you have Dr. Shanavas and Dr. Joso, who have planned and is the important persons behind the PG Club program, which has become an important activity of IAP Kerala State Branch. And I see, this is a blessing in disguise, in the sense the corona has made us too closer because of this forum. And every evening we are like family. We are meeting every day, other day, for any of the academic programs under the banner of IAP on this Zoom platform. And I think this is a blessing in disguise given by corona, because renowned faculty in many medical colleges. When we have joined, when our times when we have joined at a college, we are not familiar with other faculties in other departments, other colleges, who become our examiners sometime later. So this is an opportunity for most of our young residents to get familiarized with the teaching experience of other faculty who are not at your place, at your institution. So this is a boon to all of you, and we should be thankful to. I'm not saying what it is. Okay. Again, I should thank, before we go into the session, I should thank Dr. Manu, who is the person behind this technical activities for this Zoom program from Kottayam IAP. So before we start the session proper, I request Darling Madam to give an introductory remarks.
Madam Muta.
Good evening, all. Happy to say a few words as introductory remarks. And as Suresh said, it is our blessing to have Riaz sir with us for this meeting. Actually, there was no other name suggested as discussion for this particular program. And I think this session will be very fruitful for all the residents and also the pediatricians who have joined this meeting. And also there should be something should come out of this meeting. Actually, we should identify pathological jaundice sufficiently early to make a diagnosis, and also if treatment is possible, that should be done at the earliest to save their lives. And that is my wish out of this particular discussion. So I wish this program more success. Over to Riaz sir for the further deliberations, sir. Thank you.
Over to you, sir, for the deliberations. Kindly continue.
Good evening, everybody. I would like to thank all of my dear colleagues of IAP Kottayam and also the faculty of Kottayam Medical College, especially Dr. Darling, for this privilege to me. And thank you so much, Suresh, for the nice, kind words of introduction and the nice words about me. I'm very happy that Dr. Srilada PR was one of my best students in Calicut, has joined your department. Now, the outline of my talk today will be, we shall discuss neonatal cholestasis from an MD or a DNB examination point of view. Well, we shall brush aside other systems like social history, development history, etc., due to the lack of time. I understand that Dr. Vishnu is one of the best PGs of Kottayam Medical College. Of course, I will be evaluating him also. So what Dr. Vishnu has prepared will be in black letters. And in between, I will be asking questions or posting comments in red letters. So you may answer in the chat box or directly to me. After the case presentation, we shall have a revision class in which I shall project questions and photographs, again from an examination point of view. These will be revision questions, so I'm sure that most of you will be able to answer these questions. Dr. Suresh may alert me if the time is over. So relax and enjoy the class. Okay, Vishnu, relax and enjoy the class, and all the best. Now, before starting, I shall give a brief introduction of neonatal cholestasis. As you know, it's indeed one of the most challenging problems encountered, not only in neonatology, but also in pediatrics and also in pediatric gastroenterology. Suresh, am I audible?
Yes, sir, you are audible. Very well.
You are audible and your slides are well projected also. Thank you, sir.
Thank you. So this is the biliary apparatus. You can see the bile, which is synthesized by the hepatocytes. It transferred, that reaches the bile duct, and finally it reaches the middle of the second part of the duodenum through the common bile duct. So when there is obstruction anywhere from its origin to the entry into the duodenum, there can be cholestasis. That is cholestatic jaundice. So what is cholestasis? Cholestasis that is present at birth or develops within the first 3 months of life rather than referring strictly to the first 28 days of life. The importance is that you don't have to strictly adhere to the first 28 days of life, that is the neonatal period. When a baby presents with jaundice, the first 90 days of life, that can be considered as cholestatic jaundice. Now, what is the biochemical diagnosis of neonatal cholestasis or cholestatic jaundice? When the conjugated bilirubin is more than 1 mg/%, when the total serum bilirubin is less than 5 mg/%, or the conjugated bilirubin is more than 20% of the total, when the total serum bilirubin is more than 5 mg/%. So these are the biochemical criteria for diagnosing cholestasis. But more important would be the clinical criteria. What are the clinical criteria? Whenever a baby presents with the history of passing high-colored urine, which stains the diaper with or without pale stools, that is cholestasis. For example, so the clinical diagnosis when a baby is passing urine like this or pale stools, that is stools like this. So actually, this is more important than the biochemical diagnosis. Suresh, kelkunnundallo?
Yes, sir. Sir.
Okay. So I would like to introduce two terms. One is physiologic cholestasis. So what do you mean by physiologic cholestasis? Can cholestasis be physiologic? Well, this is especially seen in preterm babies. Here you can see that there are a large number of transporters which are responsible for secreting bile acids into the bile. Examples are NTCP, that is sodium taurocholate co-transporting protein, and there are several other such transporting proteins. In preterm babies, these proteins may not be expressed properly, and hence they can develop some amount of cholestasis, which is a self-limited reversible condition. So this is called physiological cholestasis. Then what is transient cholestasis? Another term, transient cholestasis. Suppose a baby, there is a severe perinatal disease causing congestive cardiac failure in the fetus. For example, neonatal lupus. When a baby has got neonatal lupus, there may be congenital heart block. So when there is congenital heart block, the blood supply to the liver will be decreased, and hence there can be some amount of cholestasis. And this cholestasis will recur when the baby is put on steroids. So this is the example of a transient cholestasis. Or a child with congenital hypothyroidism. He can also present with cholestasis, and the moment he is put on L-toxin replacement therapy, the cholestasis will resolve. So these are examples of transient cholestasis. And another condition, which is an upcoming very important topic, especially for postgraduates, is citrine deficiency. So there's a condition called citrine deficiency, which can also cause a transient cholestasis. Now, what are the causes of neonatal cholestasis? Now, let's see the causes of neonatal cholestasis. Causes can be classified into extrahepatic or surgical causes. The most important surgical causes are biliary atresia and cold ductal cysts. While there are a large number of intrahepatic causes like indirect infections, the various chromosome anomalies, metabolic disorders, genetic disorders, PFIC, etc. Now, it's very important for pediatricians to classify neonatal cholestasis into a sick-looking baby as well as a well-looking baby. What are the examples of well-looking neonatal cholestasis? The classic example of a well-looking baby with cholestasis is biliary atresia. It's hard to believe that a baby with such a potential fatal disease looks so deceptively well initially. And of course, there are other conditions also like choledochal cyst, etc., congenital hypothyroidism, citrine deficiency. Whereas a thick-looking neonatal cholestasis, secondary to septicemia, herpes, HLH, GALT, that is gestational alloimmune liver disease, type 1 tyrosinemia, spontaneous perforation bile duct, etc. These are the conditions in which the baby will be looking very sick. So the duty of the pediatrician is to immediately classify the condition into an extrahepatic disease, which requires early surgery, from an intrahepatic disease, which does not require surgery. Now, Vishnu, you can start. It's over to Vishnu.
Good evening, all seniors and colleagues. I'll be presenting the case of a 4-month-old female child coming from Kottayam. She's the firstborn of a non-consanguineous marriage with the chief complaints of jaundice from birth.
Okay. Now you can see that I have highlighted 3 aspects. What are they? The gender of the baby, the place of origin, the fact that he's from Kottayam and that is born to non-consanguineous parents. Now, what is the relevance? Vishnu, what is the relevance of gender in neonatal cholestasis?
Sir, surgical conditions are more in female children.
That's very good. Yeah. So this is the clue for the surgical condition. What is this surgical condition?
Biliary post-Kasai.
Yeah, that's it. This is a post-Kasai biliary atresia. You can say that. I see that he has decompensated. So one is biliary atresia. The second one is this. What is this?
Choledochal cyst.
Choledochal cyst. So these are the 2 surgical conditions which are more commonly seen in females. What is the tip to remember this? The tip to remember this is that both surgical causes are more common in females. Now, what are the countries with the highest incidence of biliary atresia in the world? The first clue for that is this. Vishnu, what is this?
Stool color chart.
Which country did it originate from? Or was
Taiwan.
Taiwan. The country with the highest incidence of biliary atresia in the world. Number 1 is Taiwan. Second is this clue. Who is this? Vishnu, who is this?
Comes up.
Do you think he's definitely is not an Indian? He's a
Sir, the
child.
big picture is not
Japanese
there, sir.
photo is not coming, sir.
Which
That
picture?
picture
is
Second picture is not there, sir.
Second picture is not there.
Ah,
Yes,
now
yes,
it's
sir. Yes, sir. Right.
Japanese doctor.
ഞാൻ പേരും കൂടെ വന്നു പോയല്ലേ. Anyhow,
Kasai.
Kasai, Morio Kasai. This is Morio Kasai. So second country is Japan. Okay. So these are the countries with the highest incidence of biliary atresia in the world, Taiwan and Japan. A lot of research is taking place both in Taiwan and Japan. Now, which neonatal cholestasis is more common in East Asian countries? So it's like importance to we people, Asians. There's one neonatal cholestasis which is more common in East Asian countries. Recently described, so great importance for postgraduate students. Anybody in the chat box? Darli, Suresh, in the chat box, somebody can write nothing. Check the chat box.
Citrine deficiency.
Yeah, correct. Citrine deficiency. Very good. Citrine deficiency. Okay. What about Norway? Second country is Norway. Example?
Agonist syndrome.
Yeah, it's also known as Norwegian cholestasis or agonist syndrome. So, citrine deficiency is more common in East Asian countries, and we have a agonist syndrome, which is also known as Norwegian cholestasis. This is characterized by lymphedema. Okay, it's also known as the lymphedema cholestasis syndrome. Okay, Vishnu, what's the relevance of consanguinity? You said this child is born to non-consanguineous parents. Why are you worried about consanguinity? Suppose the child were born to consanguineous parents, what are the possibilities?
Autosomal recessive conditions may manifest in these children.
Yeah, can you mention a few examples?
Type 1 tyrosinemia, galactosemia,
Okay.
fructose intolerance.
Yes. Then we have tyrosinemia,
GALD.
Niemann Pick C deficiency, various types of PFIC, progressive familial intrahepatic cholestasis, citrine deficiency, GALD, bile acid synthetic disorders. A lot of important areas of metabolism which are autosomal recessive can also present with cholestasis. Then Carrolis is another condition. So consanguinity is very relevant. And Vishnu said that this child is born to non-consanguineous parents. Now coming to the antenatal history. Okay, Vishnu?
Sir. Not come, sir.
It
comes. There's no history of drug intake other than iron, calcium, folic acid in the antenatal period.
Okay, it's a question for you. Which maternal drugs may cause neonatal cholestasis? Can you mention a few drugs taken by the mother which may cause neonatal cholestasis?
Anti-seizure medications.
Very good. Okay.
Amphetamine abuse.
Amphetamine abuse, anti-seizure, and something which is very common in Western countries is alcohol abuse. Okay. Antenatal history continued. What is the significance of a history of intrahepatic cholestasis of pregnancy? Suppose the mother does give a history of intrahepatic cholestasis of pregnancy. Now, what are you worried about? What is the child likely to have?
PFIC type 3 may be that.
That is PFIC 3. Good. Now, remember that the history in this will be the intrahepatic cholestasis in the mother starts in the second trimester. First trimester, she will be fine, but she starts developing pruritus and jaundice in the second trimester, and that will usually subside after delivery. Which maternal disease may lead to neonatal cholestasis due to fatty acid oxidation disorder? Suppose the baby has got a fatty neonatal cholestasis due to fatty acid oxidation disorder. Then what may be the maternal disease? It is acute fatty liver pregnancy, AFLP. It's a very serious condition, or sometimes there may be preeclampsia with the HELLP syndrome. So you can inquire about history of all these conditions to the mother. Is it clear to you, Vishnu?
Yes.
Okay, continue.
The mother was a known case of gestational diabetes mellitus on oral anti-hyperglycemic drugs. There is no history of fever with chills and rigor in the mother or foul-smelling vaginal discharge.
Okay. Now, what is the significance of this? Why are you worried about this?
A risk factor for sepsis.
Yes, that's very good. Which sepsis, which type of, especially urosepsis? Urosepsis. Anyhow, sepsis is notorious to cause neonatal cholestasis. Okay.
No history of fever with rash.
The importance?
Intrauterine infections in the first torch infections.
Yeah, torch infections, which are actually rare nowadays. Neonatal exposure to which medication may cause neonatal cholestasis?
Ceftriaxone and sludging. Antifungal medications. Fluconazole.
Ceftriaxone, fluconazole, and the recently described drug is micafungin. Okay, it's usually used for fungal sepsis. It's a drug used in fungal sepsis. So ceftriaxone is notorious to cause cholelithiasis, fluconazole, and micafungin. These are the other drugs. Name the neonatal cholestasis syndromes with congenital heart disease.
Allergen syndrome,
Correct.
congenital rubella syndrome.
Who described congenital rubella syndrome? What's the synonym of congenital rubella syndrome? Anybody in the chat box who described congenital
Gregg
rubella?
syndromes.
Yeah, it was described by the Australian ophthalmologist Norman Gregg, and hence it's also known as Gregg syndrome. And the triad of congenital rubella is known as the Gregg's triad. Okay, Gregg's triad, congenital rubella syndrome. Then we have embryonic type of biliary atresia. There are various types of embryonic of biliary atresia. About 10% of biliary atresia is called the embryonic type of biliary atresia, which may be associated with congenital heart disease. And what is Smith? There's a condition called Smith-Lemli-Opitz syndrome, SLO syndrome, or the Smith-Lemli-Opitz syndrome. Now, what are the blood groups of the mother and the baby? Vishnu?
Mother was A positive, sir. Baby was also same.
Okay. Now, what is the importance? Why it's important to know the blood groups of baby and mother? Because the infertility causes only unconjugated jaundice. We are dealing with conjugated jaundice. So, what's the importance of knowing the blood groups of a baby and mother?
Sir, excessive hemolysis can lead to inspissated bile duct syndrome.
Which condition?
Inspissated bile duct.
Yeah, due to secondary to RH or ABA incompatibility. So suppose there is severe RH incompatibility or ABA incompatibility, there can be a condition on what is it called? It's called the inspissated bile duct syndrome. Very interesting syndrome, inspissated bile duct syndrome. Now, what is inspissated bile duct syndrome, Vishnu?
Sir, due to excessive hemolysis, the biliary sludging causes obstruction of the distal parts of the biliary tree, leading to cholestasis in the proximal part and dilatation of the radicals.
That's very good. So the excess bilirubin will accumulate as a calcium bilirubinase sludge in the bile duct. So these will be very thick secretions which can completely obstruct the distal bile duct. So then hence there will be a clinical picture which is very similar to biliary atresia. So this may be mistaken for biliary atresia. USG, as Vishnu has rightly pointed out, a very simple investigation like USG. If you do a USG, what will happen? The intrahepatic bile radicals will be dilated in this condition, whereas they will not be dilated in biliary atresia. So that's a very easy method of differentiating inspissated bile duct syndrome from biliary atresia. Okay.
Natal history, the baby was born by cesarean section with a birth weight of 3.2 kilograms.
Okay, Vishnu, what's the average birth weight of Indian babies?
3 kgs.
It's about 2.9 to 3 kg. Okay. What's the relevance of this statement? 3.2 kg.
Baby was appropriate for gestational age.
What's the relevance of birth weight in cholestasis?
Normal birth weight in biliary atresia and SGA.
Biliary atresia, you get normal birth weight, average birth weight. Okay. Name the syndrome with, the large birth weight.
Agony syndromes.
Agony syndrome is a large birth weight baby. The birth weight may be 4 kilo plus. Okay. Vishnu?
The baby passed meconium and normal colored urine within 24 hours of life.
So that's a very important statement. This baby had passed meconium and normal colored urine within the first 24 hours life. That means he did not have cholestasis at birth. Okay. Okay, Vishnu?
There's no history of asphyxia neonatorum.
Is it important?
Yes, ischemic hepatitis can occur.
Yeah, that's right. There's a condition called ischemic hepatitis. So that the blood supply to the fetal liver will be decreased. This can cause, we already discussed that, this can cause ischemic hepatitis and cholestasis. Okay, Vishnu.
Coming to the postnatal history, jaundice was noted soon after birth.
You
The
said
mother
soon
informed.
after birth. When can you Vishnu, when exactly did it start? Is that soon after?
So, the mother said that she noticed in the first day itself after the cesarean when the baby was given to her. She said it like that.
First day itself.
First day itself.
Very unusual because this cannot be unconjugated. Physiological jaundice will not manifest in the first day. Anyhow, this according to the mother, it appeared in the first day. Okay, right.
The mother informed this to the pediatrician at GH Mavelikara, and blood investigations were done on day 1, 2, and 3. All results were said to be normal. The child was not given any phototherapy or blood transfusions.
So basically, maybe the baby was not jaundice at birth. That's what we understand from this. What is the evolution of jaundice in biliary atresia? What is the evolution of jaundice in biliary atresia? When does actually jaundice commence in biliary atresia? Suppose you got a baby with biliary atresia. For example, your baby is likely to have biliary atresia. When does the jaundice begin? Will they be jaundice at birth? They will not be usually jaundice at birth. So what will happen? So initially there will be some amount of physiologic jaundice. What percentage of our babies will have physiologic jaundice? What percentage?
60% of term and 80% of preterm babies will have them.
So 68% of term babies and almost 80% of preterm babies will have physiologic jaundice. So babies with biliary atresia, they will also develop some amount of physiologic jaundice. Then what happens? In biliary atresia, gradually the conjugated bilirubin fraction increases. You know that physiologic jaundice is only unconjugated jaundice, bilirubin. So in babies with biliary atresia, gradually the conjugated fraction increases. Remember that at the same time, the indirect bilirubin, that the physiologic jaundice starts to decline. By 15 days, what happens? By 10 to 14 days, the physiologic jaundice is subsiding. Okay.
Yes.
So suppose the bilirubin at 14 days was 10 mg%, or at 10 days was 10 mg%. By 14 days, it would have come down to 5 mg%. Okay. Yes. Physiologic jaundice is. Why is it so? Because the decrease in RBC load, cephalomatomy that would have resolved, breast milk jaundice that would have subsided. So due to so many reasons, just as physiologic jaundice subsides, this jaundice is subsiding. So when the pediatrician tests bilirubin, that would have come down from 10 mg% to 5 mg%. That is the total bilirubin would have come down from 10 mg to 5 mg%. So that is very unfortunate. Why? Because this gives a false sense of security to the pediatrician. Pediatrician, from 10 mg%, it has come down to 50%. It's only 5 mg%. But at the same time, remember that the conjugated bilirubin will be slowly starting to increase, which will be missed unless you do a fractionation of the bilirubin. So this is the importance of fractionating bilirubin. Otherwise, you will miss conjugated bilirubin. What is the color of normal urine? Vishnu, what is the color of normal urine?
Normal urine is clear. Sir.
Clear. What
Light.
is in Hutchison?
Straw.
What is straw?
Straw from hay, but
കാണുന്നുണ്ടോ? പടം കാണുന്നുണ്ടോ? നിങ്ങളൊന്നും കണ്ടിട്ടുണ്ടാവില്ലേ? പണ്ട് ഞാൻ ഡാറിലേക്ക് ഞങ്ങൾക്ക് ഒരുപാട് കാണുന്നുണ്ടോ? എന്താ പറയട്ടെ കോട്ടയത്ത്?
അതെ, കച്ചി എന്ന് പറയും സാറേ. വൈക്കോലെ കച്ചി എന്നൊക്കെ പറയും.
ഇപ്പോഴത്തെ പിള്ളേരൊന്നും കണ്ടിട്ടുണ്ടാവില്ല. We have seen people like myself and Dr. Darley, we have seen Vaikol. So this is called hay.
Yes.
So it's called straw colored straw colored or amber color. Another description is amber colored. What is it due to? It's due to a pigment called urochrome or urobilin. What is the significance in acute diarrheal disorder? Why are you worried about the color of urine in a baby with acute diarrhea?
Deep colored dehydration.
If the baby is dehydrated, the urine will be dark. So this is a very important question which you should ask all babies, all mothers, babies with acute diarrheal disorder to find out dehydration. Now, so this is the typical urine, the amber-colored urine, a straw-colored urine of a normal urine, and this is the urine of a patient with cholestasis or hepatitis. This is bilirubinuria. You can see the striking difference. Now, postnatal history. What are the two questions to be asked to any child with jaundice? So not only neonatal cholestasis, any child with jaundice, you have to ask two questions to find out the etiology of jaundice. Vishnu, what is the first question? What is the second question?
Urine and stool colors.
The first question is, what is the color of the urine? The first question has to be the color of urine. The urine of normal color, that means it is unconjugated, it is hemolytic jaundice. But if the urine is like this, that is conjugated jaundice. It may be either due to hepatocellular jaundice or it may be due to cholestatic jaundice. So you ask the second question. And the second question is, what is the color of the stool? So the stool, what is this, Vishnu?
Golden yellow color.
Very good. This is the typical classic golden yellow colored stool of a normal baby. And this is the so-called pale stools of cholestasis. Is it clear to you?
Yes. Picture didn't come.
Picture kandille? Kandille?
Kandu, sir.
Okay. Now, what is the classic description of the stools of biliary atresia?
Clay colored stools.
Clay colored stool. What is the color? What is the color of clay? If you go to Kottayam, Calicut, Delhi, Madras, Bombay, wherever you go, the color of clay is like this. Kottayam to irodu ingane chattiyalakku undaville. A color adana clay kondu undakkuna chattiyana. And the color inganeyana. Why is it called clay colored stool?
Chinese clay.
Clay colored stool. Yeah. This is actually the Chinese clay. Okay. Chinese clay in the color is inganeyana. So we are actually referring to the Chinese clay. It's actually not our clay, but the Chinese clay. Chinese clay is like this. That's the reason why it's called Chinese clay. Now, what is this? One of my undergraduate students, he was a boy sitting in the back of the class. I took a class on jaundice a few days back, and he became excited and he stood up and said, "Sir, looks like a very delicious butter chicken." Do you think this is delicious butter chicken?
No, sir.
This is the classic oily, bulky, highly offensive stool of severe cholestasis in older children or children with exocrine pancreatic insufficiency. It will not be seen, remember, it will not be seen in neonatal cholestasis. Why it's not seen in neonatal cholestasis? Because these babies are never given fat-rich food. They take only breast milk. So if a baby with cholestasis is given plenty of fatty food, then he might develop such stool. Otherwise, the baby with neonatal cholestasis will never develop such stools. But this is the classic stool of cholestatic liver. This is called steatoria. Which condition should be ruled out if an older child with cholestasis passes such stools?
Cystic fibrosis.
Very good. That is cystic fibrosis. In cystic fibrosis, because of exocrine pancreatic insufficiency, they can present, they can pass such stools.
They are passing together, sir.
What is the practical difficulty of assessing the color of urine and stool in a neonate? What is the practical difficulty of assessing the color of urine and stool in a neonate? What is the practical?
In diaper, they will be collected together, so color will be different.
Okay. You can see that the diaper is already. The mother urine collect urine diaper. So you can see that the diaper is already stained like this. Can you see this? Yes. Diaper is already stained like this. And if the mother collects the so-called pale stools in this diaper, it will be difficult for the pediatrician to assess the color. A pale stool miss. So this is a real problem. Mother, so what is the simple solution for that?
Separate collection.
Yeah, the simple solution is that you can collect the stools in different transparent containers. You can collect the stool in different transparent containers like this. Okay. Another practical problem is daily observation stool. Teachers whenever there is a baby with neonatal cholestasis, you observe the stool daily. Okay. Suppose Vishnu is the PG and Professor Darley is coming for rounds. The baby is not passed stool. What will you do?
Stimulation.
In the
rectal stimulation.
Rectal stimulation. Rectal stimulation. You can, how do you stimulate the rectus? You can do a perectal examination. But remember that you should never put your index finger. Always use a little finger. If you're doing a rectal examination, please remember to insert only your little finger and never your index finger in a newborn baby. Or you can do a rectal swab. Rectal swab you can observe. This is a very simple but very effective method of monitoring the stool of a baby with suspected cholestasis. Okay. Vishnu?
No history of any abnormal urine orders.
What is the relevance of abnormal urine order in neonatal cholestasis? The clue is, what is this?
Picture,
Vishnu, what is this?
Picture not comes.
Picture on the left.
Picture is not. Picture has not come, sir.
Now comes. Cabbage, boiled cabbage,
Okay, that is boiled cabbage urine. Boiled cabbage urine. Okay, and what is this?
butter,
Either
butter,
butter. How do you correlate?
type 1 tyrosinemia,
What do you
boiled
say?
cabbage.
Boiled cabbage urine and rancid butter urine.
Fine.
Okay? In type 1 tyrosinemia, you can get boiled cabbage urine as well as rancid butter urine. Type 1 tyrosinemia. Okay. Vishnu? Yes.
It is coming.
Slide
Slide has വരുന്നേ ഉള്ളൂ.
ഒന്നില്ലേ?
ഇല്ല,
ഇല്ല
stuck
സാറേ.
ആയിരിക്കും.
Yeah.
Yes, sir. At home, the baby was found to have pale stools and dark urine by 2 weeks. This was not given importance by doctors as the child was otherwise well. The baby was taken for her 6 weeks vaccination, where she was found to have inadequate weight gain and jaundice. Blood investigations were done and the parents were reassured. The parents were not inquired regarding baby's stool or urine color at the time.
So what's your comment about this, Vishnu? This area, this should not have been done. 6 weeks.
Yes.
The baby was found to pass pale stools and dark urine by 2 weeks. 2 weeks later, this baby was passing pale stools and dark. This is always abnormal. This is always abnormal. And this was picked up even at 6 weeks. This was not given sufficient importance. They had done some blood investigation and the parents were reassured. I do not know what blood investigations were done. Anyhow, the doctors did not inquire about the baby's stool or urine color. That is really bad. കാണുന്നുണ്ടോ?
വന്നില്ല.
ഇപ്പോഴില്ല.
വന്നു sir. The jaundice persisted even after 6 weeks. The stool color was persistently pale.
Some doctors advise to expose child to sunlight. കേട്ടിട്ടുണ്ടോ അത്? What is the type of therapy called?
Heliotherapy.
This is
Heliotherapy.
heliotherapy. Heliotherapy has no place in modern medicine. Okay, heliotherapy. Exposing the sun to the angry hot sun is not going to work. It will result only in sunburns. Anyhow, in some places this is still practiced, heliotherapy. So some doctors advise the baby to be exposed to the angry hot sun, resulting in sunburns. This is called heliotherapy. Get in the heliotherapy.
Yes.
Okay, Vishnu.
Due to inadequate weight gain, the baby was started on top-up feeds from the local center at 1.5 months. Worried by the jaundice and the high urine color, the parents reconsulted a nearby center at 2.5 months, from where the child was referred to ICH Kottayam.
This child was already 4 months. Oh, no.
Yes, sir. 2.5 months the child came here. Now this admission came for reviews.
Okay. Okay, Vishnu.
There is no history of seizures, sir.
What are the causes of seizures in neonatal cholestasis? Suppose a baby with a neonatal cholestasis does have seizures. What are the causes?
Intracranial bleeds, sir. First.
The most important complication is intracranial hemorrhage. Okay. What are the other causes?
Then inborn errors of metabolism can be there.
What causes seizures? One is intracranial hemorrhage. What is the second one?
Vitamin K.
It is due to vitamin D. Intracranial hemorrhage is due to vitamin K deficiency. What else causes seizures? Hypoglycemia.
Hypoglycemia.
What are the causes of hypoglycemia? How will you correlate hypoglycemia and cholestasis?
Galactosemia.
Yes.
Fructose intolerance.
Fructose intolerance, I'll come to that later. Fructose intolerance and neonatal, I'll come to that later. Galactosemia, hypopituitarism, type 1 citrine deficiency. Okay, so many conditions. Will a neonate with hereditary fructose intolerance develop hypoglycemia?
Prelacteal feeds, if they are given, they may.
Prelacteal feed. Come in the photo?
Yes, sir.
What is that?
Honey.
Honey. It's a very common practice in the Malabar area to give babies honey. So if the baby unfortunately has got hereditary fructose intolerance, he can develop seizures. Not otherwise. Otherwise, a baby with hereditary fructose intolerance will develop hypoglycemia only when he is weaned. Complement feed കൊടുക്കുന്ന സമയത്ത് ഉണ്ടാവും.
Yes.
Okay, Vishnu.
There is no history of fever or crying during micturition. There is no history of recurrent vomiting.
No history of recurrent vomiting. Okay, Vishnu. Which neonatal cholestasis causes recurrent intractable vomiting? Vomiting where the neonatal cholestasis genetic disorder is
PFIC1.
Galactosemia. Vomiting where the one condition is galactosemia. Now, a 3-year-old child with cholestasis has a strong preference for protein and lipid-rich food. A 3-year-old child with cholestasis. This is Vishnu Narayanan. I will ask this question to the audience. So you can write in the chat box. A 3-year-old child with cholestasis has a strong preference for protein and lipid-rich food. And there is a severe aversion to carbohydrate-rich food. Chicken mutteka bangara ishtana, rice theer ishtalla. What could be the diagnosis? Anybody in the chat box? Suresh,
Dr. Ahmad has written Citrine Deficiency and Aridhiraj has written GSD.
Glycansorid disease. Glycansorid disease the first one is correct. That is citrine. This is a classic presentation of citrine deficiency. So citrine deficiency is a very important topic nowadays for postgraduate students. So this is a classic presentation of citrine deficiency. And this feature can start right from or as early as 1 year of life, so that it may not be recognized by parents. Parents are the This is a clue for citrine deficiency, even in the absence of other clinical features of citrine deficiency. Okay. Okay. Vishnu?
The child was admitted in ICH on February 17, 2022, where multiple tests, including blood, urine, and a special abdominal scan were done. She was shown to
scintigraphy area. Okay.
Yes.
Okay.
She was shown to cardiologist, ophthalmologist, and ENT doctors, all said to be normal. The baby was discharged and presently under pediatric surgery and pediatric medicine follow-up.
How old is the baby now?
Baby is now 6 months, 7 months old.
7 months. Okay. A surgery,
Surgery cheyiditilla.
So this development history is essentially normal. I will skip this particular slide. Anyhow, development history is normal. This child has got normal development. Okay, Vishnu.
The child is immunized up to the age. No adverse events following immunization. No BCG scar was present.
Now, which optional vaccine should be given to all children, not neonates, all children with chronic liver disease? Which optional vaccine should be given to all children with chronic liver disease? Anybody in the chat box? Which optional vaccine should be given to all children with chronic liver disease?
Hepatitis vaccine.
Which?
Hepatitis A vaccine.
That's the correct answer. Hepatitis A vaccine. So all children with chronic liver disease, whatever is the type of chronic liver disease, it may be Wilson disease, it may be Glycansorid disease, it may be Galactosemia. All these children above the age of 1 year should be given hepatitis A vaccine. Okay.
Nutritional history. The child is on exclusive breastfeeds. No prelactal feeds were given.
What the relevance we already discussed. Like prelactal feeds, if the baby is given honey, you may develop seizures in hereditary fructose intolerance. Okay.
Breast milk was adequate in quantity.
Now, what is the advantage of breast milk and neonatal cholestasis? Is there any specific advantage of breast milk and neonatal cholestasis? Ravina? Somebody has raised a hand. Yeah. What is the advantage of breast milk and neonatal cholestasis? Well, the breast milk fat is pre-emulsified. It's natural milk. So it is pre-emulsified. Does not require emulsification. So even in the absence of bile acid, this can be digestion medicine because this is a natural milk. What about cow's milk? Cow's milk is also natural milk that will also be pre-emulsified. But then cow's milk we will have to boil before we take it. So when it is boiled, the emulsification will be lost. So this is another advantage of breast milk, which is not mentioned in many of the textbooks. So breast milk fat is pre-emulsified. That's of great use for babies with cholestasis. Okay, Vishnu?
There is no history of recurrent respiratory tract infections or fast breathing.
Okay, here's the question. What is the relevance of this? Anybody in the chat box? What's the relevance of this recurrent respiratory tract infection in neonatal cholestasis or cholestatic liver disease? How do you correlate recurrent respiratory tract infection and cholestasis?
So cystic fibrosis, sir. Cystic fibrosis.
Cystic fibrosis.
Achil.
Okay, good. Anything else? Cystic fibrosis, alpha-1 and all children with alpha-1 antitrypsin deficiency because they can develop emphysema. Anything else?
Congenital heart disease and related associated
conditions that may be associated congenital heart disease like Gregg syndrome, that is congenital rubella syndrome, Allergen syndrome, embryonic type of biliary atresia. I had mentioned that the 10% of biliary atresia may be the embryonic type, which may be associated with congenital heart disease. Okay. And SLO, Smith-Lemli. Okay. Vishnu,
Yes, sir. Yes, sir.
Okay. Okay. Intractable pruritus, which is out of proportion to the intensity of ictus.
Yes.
This is the hallmark of which cholestasis? Cholestatic
PFICs.
PFIC 1. Like you get intractable pruritus, which is out of proportion to the intensity of ictus. PFIC 1. When can the child experience pruritus? For example, can a newborn baby have pruritus?
No, sir. No, sir.
It will be difficult for him. Then the reflexes, some neural pathways. So what will he do? He will be very extremely irritable baby.
Irritable.
He'll be constantly crying. So pruritus usually manifests only after 6 months of age, as the neural pathways necessary for scratching are not well developed till then. They can start scratching only after the age of 6 months. Is it clear, Vishnu?
Yes, sir.
Till then, he'll be very irritable and continuously crying. Okay, Vishnu?
Family history. There is no history of jaundice, any blood transfusions, anemia, abdominal surgeries, infant deaths, recurrent abortions, liver disease, or chronic kidney disease in the family.
Okay. Vishnu specifically mentioned about chronic kidney disease. This is actually a bait for the examiner. What is the bait? So he'll be tempted to ask you, what are the cholestatic liver disease that may be associated with the chronic kidney disease?
Zellweger's.
Okay. Yes, there are so many. Anybody in the chat box? What are the cholestatic liver disease that may be associated with the chronic kidney disease?
Tyrosinemia.
Okay. Tyrosinemia, correct. Then
Wolman disease.
Tyrosinemia type 1 is also known as hepatorenal tyrosinemia. Allergen syndrome, that can be renal disease. Galactosemia, that can be renal disease. What is ARC syndrome?
Arthrogryposis renal
Tubular dysfunction. Okay, that is ARC syndrome. Then we have Zellweger syndrome. I think you already mentioned Zellweger syndrome. It's also known as hepatocerebrorenal syndrome. Okay, then autosomal recessive type of polycystic kidney disease. These are some of the conditions which may be associated with cholestasis as well as chronic disease. Okay.
General exam.
Vishnu, this is the question. Okay.
Yes. The child is alert and active, was lying comfortably in the bed. Icterus was present with staining of palms and soles.
What is the significance of Kramer's criteria? Kramer criteria. You know Kramer criteria. What is the significance in cholestasis? Anybody in the chat?
Unconjugated. Bilirubin more than.
Applicable only for unconjugated jaundice. Okay. Craniocaudal progression, that's applicable only in unconjugated jaundice. It's not seen in neonatal cholestasis. Okay.
Yes.
Okay.
There's no pallor, cyanosis, clubbing, lymphadenopathy, or sacral edema.
Clubbing, clubbing is very unusual at this age. Clubbing don't have to mention about clubbing because it's extremely clubbing. Okay. Okay, Vishnu.
External genitalia.
According to Vishnu, external genitalia of the child is normal. What is the significance? Anybody in the chat box? What is the significance of external genitalia? Normal or abnormal external genitalia?
Nothing in the chat box.
Okay, right. So cryptorchidism may be seen in
Hypopituitarism
and hypopituitarism. So in hypopituitarism and Smith-Lemli syndrome may be associated with cryptorchidism. What is Billy's scrotum? It's a very serious condition. Where is it seen? Billy's scrotum?
Perforated bile ducts.
Correct. Spontaneous perforation of bile ducts may be characterized by a very rare complication called Billy's scrotum. So this is the importance of examining the genitalia of a child with cholestasis. Okay, Vishnu?
Examination of vitals, heart rate 120 per minute, regular, normal volume and character, no radiofemoral delay. All peripheral pulses are palpable equally and bilateral. Respiratory rate was 40 per minute. BP was 80/60 millimeters of mercury. Temperature was normal.
What are the causes of relative bradycardia in cholestasis?
Bile salts are deposited in the SA node causing.
So the deposition, there's the old theory, bile salts deposit in the SA node can depress the SA node, resulting bradycardia. The other cause, one more cause, in older child with the GI bleed may be put on
Beta blocker.
Beta blockers. That is the second reason why there may be relative bradycardia in cholestatic liver disease. Okay.
Head to foot examination. Anterior frontally open 2.5 to 2.5 centimeters. No facial dysmorphism.
Dysmorphism illannu parnja, that's again a temptation. You are giving bait to the examiner. So
Yes.
what is the next question? What are the neonatal cholestasis syndromes with the dysmorphism? Anybody in the chat box? Vishnu seems very brilliant and darling. We'll give a chance to the participants also. Anybody in the chat box? Neonatal cholestasis syndrome with dysmorphism.
Answered as allegedly.
Okay.
Allegedly.
Before that, you can mention Down syndrome.
Okay.
Down syndrome can cause cholestasis. So we have Down syndrome. Now, what is this? Vishnu, what is
Allegedly syndrome. Facials.
Allergen syndrome? What is this? This child is actually referred to me long back with a diagnosis of biliary atresia. Do you think it is biliary atresia?
No.
What are the findings? He's got an umbilical hernia.
Umbilical hernia. Coarse facies.
This is congenital hypothyroidism.
Yes.
This is congenital hypothyroidism. This is actually a transient cholestasis of congenital hypothyroidism. Zellweger syndrome. What does the facies resemble? Zellweger syndrome.
Facies. Yeah. Hypertelorism.
Zellweger syndrome is usually mistaken for which syndrome?
Down.
Down syndrome. It very closely resembles or mimics Down syndrome. Okay, now what is this? What is the relevance of this finding in cholestasis?
Lymphedema.
Lymphedema. How do you correlate lymphedema and cholestasis?
Norwegian cholestasis.
Norwegian cholestasis. Lymphedema is seen in Agony syndrome or the Norwegian cholestasis. What is the relevance of this finding? What is the finding here?
Polysyndactyly.
It's actually a partial syndactyly of the second and third toes. Can you see that? This is one of the most common minor malformations. Almost 90% of normal people have a partial syndactyly of the second. You can check your feet. There will be partial. 90% of all of us have got this condition. But what is the relevance in neonatal cholestasis?
Smith-Lemli-Opitz.
Very good. This may be seen in one of the features of SLO, Smith-Lemli-Opitz syndrome also. What's the enzyme defect of a Smith-Lemli-Opitz syndrome?
Cholesterol.
That is 7-dehydrocholesterol reductase deficiency. So deficiency of 7-dehydrocholesterol reductase. So cholesterol cannot be 7-dehydrocholesterol cannot be converted to cholesterol due to the absence of this particular enzyme. What is the relevance of this in neonatal cholestasis? Suppose your baby with cholestasis has got this presentation. What is this presentation, Vishnu? Or anybody in the chat box?
AGC, they have written AGC.
Arthrogryposis.
Yeah, very good. Dara Vishnu, no? Very good.
Ahmad Musa also has answered.
Okay, this is arthrogryposis congenita. This
And
is
also Achilles also.
Achilles. Okay, very good. Arthrogryposis congenita. So his creatine, one of our patients, creatine was 3.5 milligram per cent. Angane in the diagnosis.
Arthrogryposis renal disorder.
This is ARC syndrome. Arthrogryposis renal dysfunction cholestasis syndrome. Okay, ARC syndrome. So this is the ARC. We had just now, some time back, we had mentioned ARC syndrome. So when a baby with this picture has got renal failure, this is ARC syndrome. Is it clear to you, Vishnu?
Yes.
What is the GGT in ARC syndrome?
Lower normal.
Lower normal. Now Now, what will you look for in the eyes of a baby with cholestasis? What all things will you look for in the eyes?
Icterus will be present.
So you look for, yeah. Is for padam കാണുന്നുണ്ടോ Vishnu?
ഇല്ല സർ വന്നിട്ട്
ഇപ്പോഴില്ല.
ഇല്ല. ഇപ്പൊ ഒരു പടം വന്നു.
Okay.
Icterus.
Look for icterus. You look for icterus. What else will you look for? The baby has got a cholestatic liver disease. What all things will you look for in the eyes?
Posterior embryotoxin in Allergen syndrome.
അത് അങ്ങനെ കണ്ടുപിടിക്കാൻ ബുദ്ധിമുട്ടായിരിക്കില്ല. സ്ട്രിറ്റ് ലാമ്പ് വേണ്ട. So you look for cataract.
Cataract. Microcornea.
Then what type of cataract is seen in galactosemia?
Oil drop cataract.
Very good. Oil drop cataract. You get oil drop cataract. And this is one of my patients with the oil drop cataract in galactosemia. What else will you look for in the eyes? Where എന്തൊക്കെ നോക്കും?
Microcornea, vitamin A deficiency.
So you look for bite out spots. You look for bite out spots. You look for subcongenital hemorrhage. Very important. Subcongenital hemorrhage. You look for posterior embryotoxin by slit lamp examination. Posterior embryotoxin. What is posterior embryotoxin?
Thickening of the Schwall base line.
That's right. This is a thickening of the Schwall base membrane, which is a classic finding of which condition?
Allergen.
Allergen syndrome. So what are the layers of the cornea? This is a basic question. What are the layers of the cornea?
Corneal epithelium, Bowman's layer, stroma, decimate membrane, dual layer, endothelium.
We should be patriotic. We are very proud as the Indians. Why? Because Dua's membrane was discovered in Indian. What is his name? Harminder Singh Dua. Harminder Singh Dua described this in 2013. Then we have the decimates membrane. What's the decimates membrane?
Cave ring formation.
The cave ring is located in decimates membrane. Okay. What is this? Anybody in the chat box? Vishnu Allah. I'm sure Vishnu is going to answer it. Anybody in the chat box? What is this? Okay, this is not cholestasis.
Cave ring. Answered as cave ring by many.
Many. By many or many?
Many people.
Many people.
Many people. Yes, sir.
Good.
Meenu, Nisha.
Very good. Very good. They're all very good students. So how will you demonstrate cave ring?
Slit lamp exam.
Ideally, this is by slit lamp. What is the other name of slit lamp examination? Vishnu? Slit lamp examination where pera? Biomicroscopy. Okay. Slit lamp examination illade nokkan pattum. Engane nokka without slit lamp examination.
Ahmad Musa has written the biomicroscopy.
Biomicroscopy. Okay. Biomicroscopy. So slit lamp examination illengil oru student answer ചെയ്താണ്. Without slit lamp എങ്ങനെ ചോദിച്ചപ്പോൾ ഇവര് പറഞ്ഞിങ്ങനെ പറഞ്ഞത്. Sir, naked man's eye examination. Naked man's eye examination അല്ല naked eye examination. Naked man's eye examination is entirely different. So this is naked eye examination. That is without slit lamp examination. Is cave ring pathognomonic Wilson disease?
High bilirubin conditions also cave ring.
It may
Partial
be
cave ring.
may be seen in any condition with there is a prolonged cholestasis. Prolonged cholestasis. Any condition, bilirubin kondalla because of copper. Any condition in which there is a prolonged cholestasis. Which layer of cornea is cave ring seen? That is seen in the
Decimates.
this is the tip for what is KFD?
Casinophorus.
But actually it's a tip also. KFD in the Casinophorus is KFD. But a hyphen that's a tip. Cave ring is seen in the decimates membrane. Is it clear to you?
Yes.
Cave ring is seen in the decimates membrane. You just call KFD is Casinophorus disease. So what are the indications slit lamp examination in pediatrics? A short note at MDCum, DNP. What are the indications of slit lamp examination in pediatrics?
Have to look for scleritis or uveitis.
Scleritis, cataract, uveitis, cave ring, cystinosis. You can demonstrate cystine crystals. List nodules may be seen in which condition?
Type 1 neurofibromatosis.
Type 1 neurofibromatosis. Then retinitis pigmentosa, retinal tear. So many conditions can be glaucoma. All this can be diagnosed, picked up by slit lamp examination. You may get a short note on slit lamp examination in pediatrics. What's the relevance of vertical gaze palsy in neonatal cholestasis? Baby has got vertical gaze palsy. What's the relevance in
Niemann-Pick disease type 3, type C.
അങ്ങനെ തന്നെ പറയണം കേട്ടോ. വെരി ഗുഡ്. Niemann Pick disease എന്ന് മാത്രം പറഞ്ഞാൽ മതി. The only Niemann Pick disease which causes cholestasis is Niemann Pick C. So you should mention Niemann Pick C. Okay. The other feature will be gelastic cataplasm. So these are the features of Niemann Pick disease which can cause neonatal cholestasis. Now, Vishnu, have you examined the fundus of this child?
No, sir.
You not examined the fundus of this child. Now, what is this, Vishnu?
iPhone.
What is this?
Ophthalmoscopy.
I'm sure that many of you will be having an iPhone which is costing anywhere from 50,000 to 1 lakh rupees. But many of the postgraduate students do not have ophthalmoscope. Vishnu, do you have an ophthalmoscope of your own?
Yes, sir.
Very good, very good. Most of the students do not have an ophthalmoscope of your own. Kottayam Medical College ophthalmoscope you cannot take when you return. So it's very important for you to purchase ophthalmoscope, which costs only 10,000 rupees. This is a lifelong possession, and only if you have seen thousands of normal fundus can you pick up an abnormal fundus. Or abnormal fundus pick up. Only if you have seen thousands of normal fungi can you pick up an abnormal fundus. So you should always practice on your friends, your roommates, on all your patients, especially patients who are older children. Okay. This is lifelong possession, unlike iPhone. iPhone 50,000, 1 lakh rupees whereas this ophthalmoscope is a lifelong possession. So all postgraduate students, if you're not already purchased an ophthalmoscope, please do purchase one. So what is important in the fundus? You not examine the fundus. Vishnu?
Yes,
Is it
sir.
important?
Yes,
What
sir.
What is this?
Retinitis pigmentosa.
Very good. Well, how will you correlate neonatal cholestasis and retinitis pigmentosa?
Zellweger syndrome.
Retinitis pigmentosa. Very good. Zellweger syndrome. Now, what is this?
Cherry red spot.
Yeah, that is cherry red spot in
Niemann Pick disease.
Niemann Pick C. Okay. What is this?
This pallor.
Very good. So, what is it then? This is a normal fundus. This is a normal fundus. Okay. And the second one shows pallor. So, how will you correlate a pale fundus and neonatal cholestasis?
Optic atrophy.
Which condition? Anybody in the chat box? Chat box. Septo-optic dysplasia.
Optic atrophy they have written.
Okay.
Septic dysplasia also they have written.
Okay.
Ahmad Musa.
What's the synonym of septo-optic dysplasia? Anybody? Ahmad Musa.
Demorisia.
Very good. That is Demorsia syndrome.
Ahmad Musa sir has written.
Okay. Ahmad Musa is actually my student in KMC. Okay, good. Yeah. So Demorsia syndrome. Vishnu?
Yes. Oral cavity, there was no bleeding manifestation. Skin, no petechiae, ecchymosis or hyperkeratosis. Chest, abdomen and extremities were normal.
This is the anthropometry. We will not discuss further the anthropometry due to the lack of time. What should you be conscious about anthropometry in these children? A child with cholestatic liver disease. What is the importance of anthropometry? Remember, the ascites and hepatosplenomegaly may contribute to the weight of the child. Okay, so this may give a false sense of good somatic growth. So what will you do? How will you circumvent this? You can measure the mid-upper circumference skin fold thickness. So these are actually much reliable indicators of nutrition status of children with decompensated chronic liver disease with ascites and massive hepatosplenomegaly. Now, what is this? Upper arm less likely to be affected with edema. Edema upper arm very good. Okay.
Yes.
Now, what is this? Chat box.
Harpenden.
Very good. This is Harpenden. This is called Harpenden's caliper. Okay. Harpenden describe the wear instrument. Can you mention one instrument, describe another instrument?
Yes, that is
stadiometer. Stadiometer is described by Harpenden's stadiometer. And we have the Harpenden skin fold caliper as well as you have the Harpender's stereometer. Okay. Examination of the abdomen. Okay.
Abdomen.
കാണുന്നുണ്ടോ?
There is no dilated veins or visible mass. Umbilicus normal and central.
Now, what is this?
Massive abdominal distension.
Yes.
Umbilical hernia and incisional hernia. Dilated veins.
Umbilical hernia, yes. Yes. Pinna?
Dilated veins.
Anti-abdominal wall. Very good. He has picked up all the findings. So what is the significance of dilated anti-abdominal wall veins?
Portal hypertension.
Portal hypertension. That's the third year. That's a UG answer.
Extrahepatic.
Second to Vishnu is one of the best students. He says that in extrahepatic portal hypertension, you will get this. Whether the question, I'll try to explain that. Don't worry, Vishnu. I'll try to explain that in detail. So Vishnu said that in extrahepatic portal hypertension, you will get. I'll discuss. It is actually intrahepatic portal hypertension. I will discuss why you get dilated veins only in intrahepatic portal hypertension. Now, what is this, Vishnu? You're not read Mahabharat, Vishnu?
Yes, sir. Yes, sir.
Who is this? What is this? In Mahabharat, what is this? Anybody in the chat box?
No answer.
Yeah, that's right. This is Kijagavadam. Okay. You know that Kijaga was destined to be killed by whom? Kijaga was destined to be killed by Bhim. So if Kijaga has been killed, and Arthandana, Bhima or Pandavas are around. Pandavas are responsible or Bhima is. The Chatta the Kijagana, similarly, if there are dilated anti-abdominal veins, the pathology is within the liver. It is intrahepatic portal hypertension and not extrahepatic portal hypertension. Okay. Now I will explain that why it's so. Okay, Vishnu?
Yes, sir.
Now I'll discuss the anatomy of the portal vein. You know that the portal vein is about 8 centimeters long. It's formed by the union of the splenic vein and the superior mesenteric vein. And it has two parts, the extrahepatic part, which is long, and a very small intrahepatic part, which divides into two parts, the right and the left. Is that clear to you?
Yes.
Long extrahepatic part, short intrahepatic part, which divides into right and left branches. And remember that the umbilical vein actually joins the left branch. It is the probe-patent umbilical vein, which joins the left branch of the intrahepatic portal vein. Is that clear to you?
Yes.
You can see the umbilical vein. You can see the blood flowing from the portal vein into the liver.
Yes.
Okay. Now, this is the hepatic architecture. You can see the large number of hepatocytes. You can see the portal triad. Portal triad, now we have the portal vein. Can you see the portal vein here?
Yes.
This is the hepatic artery, and the blood in the portal vein that flows, blood from the portal vein and the hepatic artery will be flowing into the sinusoids. That's clear to you.
Yes.
Okay. But normally, a problem because this blood will reach the central vein. And from the central through the hepatic veins, it will reach the inferior vena cava. Is that clear to you?
Yes.
Okay. Now, when the patient develops cirrhosis, what happens? When there is cirrhosis, there is fibrosis. So all the sinusoids will be obstructed by occluded by the fibrous tissue. So what will happen now? The blood from the portal vein, it's not able to flow into the central vein. So the pressure in the portal venous radicals is increasing.
Yes.
So when the portal venous radical pressure is increased, naturally that will be reflecting on the large portal vein also. Portal vein also big portal vein end.
Yes.
So if there are millions of portal venous radicals and the pressure that is when there is intrahepatic portal hypertension, the pressure within the intrahepatic portal vein, large vein, will also be increased. Okay. Up in the victim, now the blood will start flowing from the left branch of the portal vein, left branch of the portal vein through the probe-patent umbilical vein. Now look at this photograph. Through the umbilical vein. In the umbilicus in the chutum, there are collaterals. So this blood will drain into the collaterals around the umbilicus. And these are responsible for the dilated anterior abdominal wall veins. Is that clear to you?
Yes, sir.
Okay. Okay. If that is clear to you, I will go to the next slide.
Yes.
Okay. So sinusoidal pressure increases in cirrhosis. Okay. Portal venous pressure increases. Blood flows through the umbilical vein to paraumbilical veins, and that will result in dilated anti-abdominal wall veins flowing away from the umbilicus. This is the reason why you get dilated anti-abdominal wall veins in intrahepatic portal hypertension. Now we'll see extrahepatic portal hypertension. So this is cirrhosis intrahepatic portal hypertension. We already discussed it. See a patient with extrahepatic portal hypertension. Where is the obstruction here? The obstruction is in the extrahepatic part of the portal vein. Obstruction. So what will happen now? The blood from the portal vein is not at all reaching the liver. So naturally, the portal venous pressure within the liver can never be increased. So that means blood cannot flow through the umbilical vein because the pressure within the liver is normal or even decrease. Why? Because the blood from the portal vein is not able to reach the liver. Okay. So in a patient with extrahepatic portal hypertension, there is no question of blood flowing through the umbilical vein because the pressure within the liver is normal. Vishnu, is it clear to you?
Yes, sir.
Okay. So in extrahepatic portal hypertension, you cannot get dilated anti-abdominal veins. Okay. Now, what are the clinical signs to demonstrate the direction of blood flow in a vein, anti-abdominal vein? What's the clinical sign? And anybody can remember that? Chat box. What the clinical sign to demonstrate
Direction of flow.
direction kandupidikkanna sign the parent. Anybody in the chat box? Suresh?
No one in chat box.
Okay, okay. That's called Harvey's sign. Okay. Harvey's sign, you identify a vein that is free of branches for at least 3 centimeters. This branch is free of branch at least for 3 centimeters. Then you can place and press 2 fingers close together over the middle of the vein. Then both fingers are moved in the opposite direction, that you are milking and emptying the vein.
Yes.
You are milking and emptying that particular vein. This results in complete emptying of the vein. Then what you do next? Finally, one of the fingers is released and the speed of the filling of the vein in one direction can be observed.
Yes.
Then you can identify every can blood flow in the. This sign is called the Harvey's sign. Okay, this is a clinical sign called the Harvey's sign. Is it clear?
Yes, sir.
Okay.
Yes, sir.
There's a quiz for you. Anybody in the chat box? I think
No one in the
chat box. Quiz you can write in chat box. I think Vishnu is too brilliant. We'll give a chance for the other participants also. What is sinistral portal hypertension? If not, that will go to Vishnu. Anybody in the chat box? What is sinistral portal hypertension?
No one there in chat box.
Okay, Vishnu, we'll got the Pandit. The Pandit is
That
Vishnu.
is
Vishnu.
splenic vein, sir. In Akhil Musa's written intrahepatic.
Okay. Intrahepatic.
Splenic vein hypertension.
That's right. Sinistral sinistral means left-sided. Okay, portal vein.
Left-sided. Meanwhile, is written left-sided.
Left side. Okay. Left-sided left side is sinistral. Portal vein, splenic vein forms the left part of the portal system. When there is a portal vein thrombosis, what will happen? You get varices only in the stomach. You don't get gastric varices in the esophagus. Esophageal varices will not be seen in left side of portal hypertension. Only gastric varices. That's the importance of sinistral portal hypertension, which is also called a left-sided portal hypertension. This may be a complication of pancreatitis. Why? Because pancreas, splenic vein, and close. So if there is pancreatitis, there can be splenic vein thrombosis. Now, examination of the abdomen. Okay, Vishnu?
The abdomen was not distended.
Abdomen is not distended because we are presenting now. At the time of exam, abdomen is not distended.
Abdomen is not distended.
What are the 3 important causes of abdominal distension in children? Chat box. There are several causes. I want the 3 major causes of abdominal distension in children? 1, 2, and 3. Anybody in the chat box?
Somebody has written mass.
Mass, okay. Before that, the very rare condition.
Ascites.
Even before that, massive organomegaly. A massive hepatosplenomegaly, massive organomegaly. This is in fact one of the most important, one of the most common cause of abdominal distension in a pediatric age group, followed by severe ascites and, as somebody rightly mentioned, a lump in the abdomen, which may be due to Wills tumor or a neuroblastoma. So these are the three important causes of abdominal distension. There may be other causes. These are the three major causes. Now, what are the features of abdominal distension due to organomegaly? Suppose a patient has got organomegaly, for example, hepatomegaly. What are the features of abdominal distension due to organomegaly alone? History of gradual onset of upper abdominal distension spanning over years. Suppose a child presents with a history of അമ്മ പറയുന്ന കുറെ മാസമായിട്ട് അതിന്റെ അപ്പർ അബ്ഡോമിനിൽ അപ്പർ പാർട്ടിൽ മാത്രം ഇങ്ങനെ ഒരു വീർത്തമാതി വരുന്നു തോന്നുകയാണെങ്കിൽ what is the possibility? Something like this. What the this is the classic spot in pediatrics. What's the diagnosis, Vishnu? ഒരു isolated hepatomegaly ആണ് അല്ലേ? Look at the face, chubby cheeks.
Von Gerke's disease.
This may be a Von Gerke, or this is a type of
glycogen storage
disease. The anganaiyulla kuttikal present only with upper abdominal distension. Kore naalathikku angane undayirikkum. Okay, then that is hepatomegaly with or without splenomegaly. Hepatomegaly may be associated with splenomegaly, but not isolated splenomegaly will not cause such an abdominal distension. I will come to that later. Now, suppose such a child, ee kuttike korchu kayinte generalized abdominal distension vannu vicharikka. So initially he was having only upper abdominal distension, and later he develops generalized abdominal distension. Then what is the possibility?
Ascites.
The possibility is that the progression of the hepatomegaly. Hepatomegaly is progressing. It is now reaching the right iliac fossa. It's a huge hepatomegaly. So it was only minimal or borderline moderate hepatomegaly. Now that is a massive hepatomegaly. So that is one cause why there is a generalized abdominal distension. Second cause is he has developed decompensation and he has developed ascites. Is that clear to you?
Yes.
Upper abdominal distension മാത്രം വരുന്നു. Then generalized variant, it may be either due to massive hepatomegaly or it may be due to decompensation when the patient develops ascites like this. Okay, Vishnu, can I talk?
Yes.
Go to the next slide. Okay.
Yes.
Now, what are the features of abdominal distension due to isolated massive splenomegaly? നമ്മൾ hepatomegaly പറ്റി പറഞ്ഞു. Suppose a child has got an isolated massive splenomegaly. Will it cause upper abdominal distension? Usually not. Why? This usually presents as a let's say a lump. Usually this presents as a lump in the isolated splenomegaly. Usually presents as a lump and not as a upper abdominal distension. But along with the hepatomegaly, it can present as a generalized abdominal distension. Is that clear?
Yes.
Isolated massive splenomegaly, usually that presents as a left-sided lump. But if there is an associated hepatomegaly also, then that can present as a generalized abdominal distension. What about nephrotic syndrome? What are the features of abdominal distension due to ascites of nephrotic syndrome? Adilum decompensated liver disease ascites vera, nephrotic syndrome ascites vera. How will you differentiate? Either
Short duration.
Short duration, 1 to 2 weeks, then remain static thereafter. Why? Because there is an equilibrium between absorption and secretion. There is always an equilibrium between absorption and secretion. Okay, and other features of nephrotic syndrome will be so it may be possible, should be possible for it to differentiate ascites and nephrotic syndrome from that of decompensated liver disease. So this is the difference. Now, how will you palpate liver? I do not know. Dr. Darley, do you want to discuss palpation of liver?
Yes, sir. We can do.
Okay. Okay. How will you palpate liver? What is the first step? Permission is very important. Second step എന്താണ്? നിങ്ങൾ എന്താ ചെയ്യേണ്ടത്?
Introduce
take sweets, toffees. Never forget to take sweets and toffees to the examination hall. You can give toffees to the sweets to the children. You can also give to the examiners. We also like toffees, sweets. So permeation, wrapper, and sanitization. Sanitize, then a wrapper is very important. Always stand on the right side of the patient. Warm your hands like this. Then start from the right iliac fossa with fingers parallel to the right costal margin. Ask the patient to breathe in and out through the mouth. Gently move up to the right upper quadrant, lateral to the rectus abdominis muscle. Okay?
Yes.
With each expiration, move your hand up by 1 to 2 centimeters. Expire you move your hand by 1 to 2 centimeters. During inspiration, you keep your hand still. You wait for the liver edge to meet it. The liver edge will come down to meet your fingers. Okay? If the liver is enlarged, it will come downward to meet your fingertips. Now, suppose you have found the lower edge of the liver. Lower edge of the liver control. What is the next step, Vishnu? What should you do?
Mark it.
Mark here?
Pencil.
Pencil and mark here. Most
non-permanent
will be using your pen. You should never mark with somebody's abdomen with pen. Always use chalk. In the pen mark and don't forget to rub it. Pen mark suppose the liver is palpable 2 centimeters. You have marked it as 10 centimeters. So what will happen? You will not only fail yourself, but also your friend who comes next. You're asking. Your friend your liver is palpable 10 centimeters, the liver may be just 2 centimeters. So if you do not rub it off, this is what's going to happen. So always bring chalks to the examination hall. Never forget to bring chalks also to the examination hall. Then you should demonstrate the span of the liver. To the lack of time, I will rush through the slide. You always draw the midclavicular line. Never forget to draw the midclavicular line. Identify the angle of Louis. Start percussing from the second left intercostal space till you get dullness. Dullness, you should mark it again with a chalk. You do a tidal percussion to make sure that it is the liver dullness. Then the mark the area. Then you find out measure the area between the two markings to get the span of the liver. Is it clear to you? I'm sure you'll be knowing all this. Vishnu, okay, you ready, Vishnu?
Yes, sir.
Okay.
The liver was palpable 4 centimeters below the right posterior.
Liver is palpable, not
liver is palpable 4 centimeters below the right posterior margin in the midclavicular line. It was firm, non-tender, with a smooth surface and sharp border, with a span of 7.5 centimeters.
You said it's firm liver. What is the cause of a soft liver?
Normal liver.
Very good, very good. This is normal liver. You know that liver will be normally palpable in the infants up to 2 centimeters. So normal liver will be soft. Then acute congestion. Early stage of viral hepatitis, the liver will be soft. Early stage of viral hepatitis. And as you rightly mentioned, acute congestive cardiac failure. Always mention acute congestive cardiac, because in chronic congestive cardiac failure, it will be firm. And fatty liver also, it will be usually soft in consistency. Okay. Okay. Vishnu?
The left lobe of liver is palpable 2 centimeters below the xiphoid process.
Okay, there's a question to you. Question to the audience also. What is the cause of disproportionate enlargement of the left lobe in cirrhosis? It's a common knowledge, common finding that in a child with established cirrhosis, the right lobe may not be palpable, it may be just palpable, whereas there is a disproportionate enlargement of the left lobe. What may be the mechanism? Anybody? Vishnu and Aryo?
Hepatotrophic factors, Musa has written.
Ahmad Musa, okay, good. Anyhow, that requires some explanation. I'll try to explain that. You know that splenic vein, this is a splenic vein, this carries hepatotropic factor from the pancreas. Because the pancreatic veins actually open into the splenic vein. So the splenic vein actually carries hepatotropic factor from the pancreas. And this is supplied normally equally to both lobes of the liver, right lobe, left lobe. So the hepatotropic factors from the pancreas carried by the splenic vein, these are normally supplied equally to the right lobe and the left lobe. Is that clear?
Yes.
No? Okay.
Yes.
Now, in cirrhosis, what happens? The hepatic architecture is completely altered and the blood flow is altered. So what will happen? In such a manner that the splenic vein, splenic blood with hepatotropic factors is supplied preferentially to the left lobe and not to the right lobe. But left lobe in hepatotrophic factors that hypertrophies. At the same time, the right lobe does not receive this blood, and hence it does not get hepatotrophic factors, resulting in atrophy. Is that clear to you, Vishnu?
Yes.
Because of the hepatotrophic factors. In cirrhosis, the hepatic blood flow is altered in such a manner that the blood from the splenic vein with its hepatotrophic factors is preferentially shunted to the or supplied to the left lobe and not to the right lobe. And hence the left lobe hypertrophies and the right lobe atrophies. Okay, can I go to the next slide, Vishnu?
Yes, sir.
Now, what are the signs of ascites?
So, dullness, shifting dullness, fluid thrill.
For that, we always start with the flank dullness.
Flank.
Then we have what's called horseshoe dullness. Then we have shifting dullness. Then we have fluid thrill, and then we have puddle sign. These are the signs of ascites. Okay, what is horseshoe dullness?
Dependent pause.
Moderate ascites, what will happen? The fluid will accumulate in the hypogastrium as well as in the flanks. So if you percuss, it will be like the flanks and hypogastrium are dull, and the bowels with the gas will float up. You can see that the bowels with the gas will float up. So the periumbilical area will be resonant to percussion. So flanksum, hypogastrium, dull light. So this is just like a horseshoe. That's the reason why it's called horseshoe dullness, which is usually seen in moderate ascites. Now a word about shifting dullness. Patient lies supine initially. You percuss from the midline to one side till you get a dull knot. Okay. Then you tilt the patient to the opposite side like this, to one side like this. Wait for 30 seconds, percuss again, and repeat on the other side. This is how you demonstrate shifting dullness. What is the mechanism of shifting dullness? Supinated article sample, you can see, bowel filled with the gas floats upward in the ascending. But central will be resonant. Flanks will be dull. When the patient is put in the lateral position, what will happen? The bowels, that will become resonant. That's the mechanism or rationale of demonstrating shifting dullness. This is fluid thrill. Patient again lies in the supine position. Applied pressure on the midline by the patient or by an assistant. Keep one hand on either flank. Tap one side while feeling for a wave on the other side. Okay. Now what is this?
Puddle sign.
Puddle sign. Okay. Who was Dr. Puddle who described? Vishnu Narya. Who was Dr. Puddle who described puddle sign? Anybody in the chat box? Who was Dr. Puddle who described puddle sign? Anybody? Who was Dr. Puddle? Was a pediatrician, was a gastroenterologist, or a cardiologist? Vishnu? Whom would you choose? Gastroenterologist, cardiologist, or pediatrician?
General surgeon.
General surgeon. Very interesting answer. You want a general surgeon. Okay. Anyhow, puddle was not a doctor. Puddle is just a collection of water. ഒരു മഴ പെയ്ത് കഴിഞ്ഞാൽ പെട്ടെന്നൊരു ചെറിയൊരു മഴ പെയ്ത് കഴിഞ്ഞാൽ ഒരു കളക്ഷൻ വാട്ടർ അല്ലേ, അതിനെ പഡിൽ എന്ന് പറയാം. കാലിക്കൽ തന്നെ നീർച്ചാൽ, എന്താ പറയുക, വെള്ളച്ചാൽ എന്താ ഒരു വാക്ക് ഉപയോഗിക്കാറുണ്ട്, നീർച്ചാൽ എന്നൊക്കെ പറയും. ഓക്കെ, സോ പഡിൽ is only a collection of water after sharp shower. It's not Dr. Puddle. But don't try to demonstrate puddle sign. It's a very cumbersome, extremely difficult. Okay, you should never try to demonstrate puddle sign even in the exam. Even if the examiner asks you to demonstrate puddle sign, it's very inconvenient and difficult for the patient. Now, how will you grade ascites? Grading of ascites. This is the grading of ascites: mild or grade 1, grade 2 or moderate, grade 3 or massive. Grade 1 is detected by USG or puddle sign. Moderate and marked abdominal distension. Okay. Vishnu?
There is no murmur heard.
What is the significance of murmur?
Associated CSDs like in congenital rubella syndrome and Palpate syndrome.
Abdominal. We are examining. Vishnu, you are actually examining the abdomen. You are examining the abdomen.
Yes.
Not just.
Hepatic bruit.
Hepatic bruit. There is a photo.
Yes, sir.
Yeah, what's that?
Dilated vein.
So, sign, the parents are very fond of it.
Carvalian Brahmandan sign.
Dr. Darley?
Vishnu and Amal Musa.
Okay, that's right. So this is called a Crewell-Baumgarten Mammen, which is suggestive of cirrhosis with intrahepatic portal hypertension.
Yes, sir.
A continuous murmur in intrahepatic portal hypertension, and this murmur is called Crewell-Baumgarten or sign number. Crewell-Baumgarten murmur sign number. It's always abnormal. It is never going to be normal. This is a sign of intrahepatic portal hypertension. Okay, Vishnu.
Respiratory system. The trachea was central, chest wall normal in shape, chest wall movements. The trachea is central, the chest wall is normal in shape, chest wall movements were bilaterally equal. Breath sounds are heard equally in all areas, no adventitious sounds. Cardiovascular system, S1 and S2 is heard normally, there is no murmur. Central nervous system, the child is moving all four limbs, tone is normal and reflexes are normal.
I had promised that we will not discuss other session, but CNS, central nervous system. Actually, you are examining not only the central nervous system, you are examining the peripheral nervous system, you are examining the autonomic nervous system. So it's better to say nervous system than central nervous system, because you are BP. It's actually part of autonomic nervous system. So it's better to say nervous system rather than central nervous system. Okay, summarizing a case. Now remember that summarizing a case is an art which has to be perfected. And students usually do very badly when they're asked to summarize it. Summarize it. So this is an art which has to be perfected. This should be like a micro mini skirt, which should be very short, which should be exciting, and should reveal everything in a short span of time. Okay? Now let's see how Vishnu is summarized. This is a summary sent to me by Vishnu. This is a part of the summary. Hello, Vishnu? This is the part of the summary sent me. Now I'll go to the remaining part of the summary. Is it a long skirt or a short skirt, Vishnu?
Long.
It is a very, very, very long skirt. Photo Vishnu? Photo? Okay, that's a long skirt. So I have summarized for Vishnu. Let's see my summary. So, a 4-month-old girl. What is the importance of a girl? But that is implying that this may be biliary non-consanguineous. That's important. Also, that indicates that this is unlikely to have an inborn error of metabolic. Galactosemia. History of persistent pale stools. That's the finding in biliary atresia. Bakilla condition like you get the intermittent pale stools. So I written persistent pale stools. And of course, high colored urine since birth. No dysmorphism. I am ruling out dysmorphic syndromes, including Allergen syndrome. No microcephaly or cataract. I am ruling out intra-uterine infections. Unlike rubella, cytomegalovirus, hence, she has cholestatic liver disease, most probably biliary atresia with cirrhosis and portal hypertension. Is it a short skirt or long skirt?
Short.
This is a short skirt. So your summary should be like this and not like that. So all postgraduates like you, then practice is not. But time there should be everything. This summary, I think we have got almost everything that we want. Okay. Now Vishnu, coming back to Vishnu, what are the points in favor of biliary? Why do you say it's biliary atresia? What are the points in favor of biliary atresia?
Girl child.
Very good. Basics that are very good. The gender is a girl child. Then the term
baby, normal birth weight.
Normal birth weight. Very good.
Non-sick looking child.
Okay, not sick. Okay. Persistent, markedly pale. Not sick looking. Very good. No, not sick. At least initially, these babies will not be sick looking at all. So persistent, markedly pale. Now, how will you evaluate neonatology if the baby is very sick, or if the FTT or a pulmonary hepatic failure? How will you evaluate?
Rule out sepsis.
Always rule out sepsis, because this is a treatable disease. Urosepsis and you do urine culture, blood culture, you get an antibiotic, you start antibiotic, the child is going to be all right. So rule out sepsis. Always rule out galactosemia. Simple test and non-glucose reducing substance. Suppose the ferritin is very high. What are the possibilities?
Gal,
HLH. HLH. Okay. Very high alpha beta protein. 1 lakh alpha beta protein.
Tyrosinema.
Type 1 tyrosinema will cause type 2 so type 1 tyrosinemia. Suppose serum lactate is high.
Mitochondrial disorder.
Very good. Mitochondrial hepatopathia. Then do the test for gall. What is the best test for gall?
Biopsy.
Lip biopsy. I'll come to that later. Lip biopsy. MRA of abdomen for hepatic hemochromatosis is a good test. It's a very difficult in a cumbersome test in a neonatal. Lip biopsy is a very simple test that can be very easily done. So these are the tests which may be done if the baby is sick. Role of bone marrow. Eppala bone marrow useful ava HLH bone marrow is very useful. HLH. There are different types of biliary atresia. We are actually discussing biliary atresia. The classic biliary atresia is the perinteral biliary atresia. Almost 80%, 85% maybe classic biliary atresia without other anomalies or malformations. Okay. So they will be born without jaundice. Remember, they will not be having jaundice, but they may develop jaundice within the first 2 months of life. That is cholestatic jaundice within the first 2 months of life. Remember that they may be having physiologic jaundice. 60 to 80% of all babies will be having physiologic jaundice. So babies with classic biliary atresia may also present with physiologic jaundice. Then gradually that is replaced by the cholestatic jaundice. Now what's the diagnosis here?
Isomerase.
What are the findings?
Dextrocardia, situs inversus.
Very good, very good. This is dextrocardia with the situs inversus. So this may be the embryonal type of biliary atresia. What is known as the BASM. BASM biliary atresia, splenic malformation syndrome. Biliary atresia, splenic malformation syndrome. About 10 to 15% may be this type of biliary atresia. And this may be associated with the congenital heart disease. That's why we recurrent LRA variant be the embryonal type of biliary atresia also. And the third type is very rare type, biliary atresia with other congenital malformations, including intestinal atresia, imperforate tinnitus, renal anomalies, etc. This is extremely rare. When does jaundice appear in biliary atresia? We already discussed it. Remember, it may appear from birth up to the 2 months. In 2 months, biliary atresia by 2 months, there will be jaundice. But by 2 months, before 2 months, all would have developed jaundice. What are the screening tests for the biliary atresia?
Stool color.
One is stool card. Stool card, I'll discuss that. But then a very important one is serum conjugated bilirubin level during the first few days of life. If a newborn baby has got increased conjugated bilirubin, that should be taken as a criterion for diagnosing cholestasis, and you should be very careful. And what the recently described investigation? Aryo. Recently described investigation for screening for biliary atresia. Anybody in the chat box? That is serum level of MMP, matrix metalloproteinase 7. This is a recently described test. Matrix metalloproteinase 7. Matrix metalloproteinase 7. Okay.
Musa has written that, sir.
Okay, good. Matrix metalloproteinase 7. Good, Musa. Which metabolic genetic disease can present like this? What is galactosemia can present like this?
Tyrosine.
HFI, type 1 tyrosine, PFIC, Allergen, all these conditions may be mistaken for biliary atresia. Which disorder the lipid metabolites may present with cholestasis? Niemann-Pick C and Gaucher type. Rarely Gaucher type 2 can also present like this. It's rare. Remember Wallmann's disease. What is Wallman? What is the typical radiology finding of Wallmann's disease, Vishnu?
Adrenal calcification.
Very good. Adrenal calcification. Darli, I think you got a very good, very bright PG. I think he's going to become a pediatric gastroenterologist.
I know. No, sir. Yes.
I think he'll become a pediatric gastroenterologist shortly.
Definitely.
So how will you investigate this child, Vishnu? How will you investigate this child?
Initially, evaluate all the baseline investigations, including complete blood count.
It's very important to do a complete blood count. And people usually start with LFT, GGT. No, it's very important to do a CBC. Why should you do a CBC? Because you want to know if the baby is anemic. What is the importance of CRP?
Sepsis.
Urinary
UTA.
UTA. What are the causes? Suppose the hemoglobin in a baby with cholestasis is less than 6. Bangara anemia, what are the possibilities?
Inspissated bile duct syndrome.
Oh, very good. One is inspissated bile duct syndrome. Very good. Second one is intrauterine infection. Which intrauterine infection can cause severe anemia? Toxoplasmosis. Severe anemia ഉണ്ടാക്കുന്നത് it is parvovirus-19. Erythropoiesis is parvovirus-19. What is the current name for parvovirus-19 virus? What is the current name, latest name for parvovirus-19 virus? Chat box. Vishnu? It's called erythrobi virus. Erythrobi virus. Erythrobi-19.
Musa has written that, sir. Erythrobi virus.
Erythrobi virus. So, as Vishnu Vardhamadi, inspissated bile duct syndrome and intrauterine infections, really parvovirus-19 may cause severe anemia. Low platelets are seen in which neonatal cholestasis syndrome. Low platelets. That is intrauterine infections. Most of the intrauterine infections you get thrombocytopenia. It may be due to hypersplenism also. So these are the two causes of thrombocytopenia. Investigation conduct. Then you do it. Then only come to LFT. Other than LFT in the parade. Then you do LFT. LFT in which neonatal cholestasis syndrome transaminase may be only minimally elevated. Transaminase is elevated. Our condition is
Biliary Apparatus.
Biliary Apparatus. Okay. One is metabolic liver disease. In addition to biliary apparatus, in some of the metabolic liver disease also, the transaminase may be only mildly elevated. 100 to 100. Another one, of course, as I said, is biliary. Biliary apparatus initially, the transaminase may not be very high. In which neonatal cholestasis is AST more than ALT, SCOT more than ALT. Remember that the source of AST is concentrated in the mitochondria. So in mitochondrial hepatopathy, AST will be more than ALT. In mitochondrial hepatopathy, AST will be more than ALT.
Musa has written that.
Okay. Next is GGT. Vishnu?
Yes.
Name the surgical condition with very high GGT or highest GGT with a surgical condition. You want a clue?
Yes.
You are discussing that condition now. Biliary
Apparatus.
So name the medical condition with very high GGT.
PFIC3.
The correct answer is Allergen syndrome. The medical condition is Allergen syndrome and the surgical condition is biliary apparatus. PFIC3 but not as high as in Allergen syndrome. So that's the reason why sometimes it will be very difficult to differentiate Allergen syndrome from biliary apparatus. Name the neonatal cholestasis syndrome with a high ferritin.
GALD and HLH.
GALD, very good. HLH. Name the specific test for tyrosinemia type 1.
Urinary succinyl acetone.
Succinyl acetone, very good. Succinyl acetone. This should be sent only if stool is pigmented. Stool markedly pale stool and clay color stool, that is biliary apparatus. No need to send blood for tyrosinemia. What's the role of blood sugar?
Hypoglycemia associated.
Galactosemia. We discuss type 1 tyrosine, cortisol deficiency, citrine deficiency, all these conditions, mitochondrial hepatopathy, all these conditions can cause hypoglycemia. How many PFICs are there now? This is a very important topic for post graduates. PFIC.
6 variants.
But actually there are now more than 6 and 6 or 7, 8 I can describe it. At least there are 6 now. The only PFIC with high GGT is, I think Vishnu had already answered that is PFIC3. The only PFIC with high GGT is PFIC3. How will you differentiate bile acid synthetic disorders from PFIC?
Abnormal bile will be accumulating.
Serum bile acids will be low in bile acid synthetic disorders. They will be high in PFIC. No. Then low in serum bile acids will be low in bile acid synthetic disorders. They will be high in PFIC. Another quiz for you. Which molecule is used in cholecystography? The test is, you said you had used a word, but a special Hida. Actually, we are not using Hida. Hida pandu bechasanan. But the molecule is mebrofinin. Mebrofinin is much superior to Hida. So due to the lack of time, I will skip some of the slides. This is the mebrofinin or the old pair Hida scan. You can see that the isotope is concentrated in the liver. It is not coming out of the liver into the into the intestine. So this is biliary atresia. On the other hand, in neonatal hepatitis, you can see that it is coming out from the liver into the intestines. So this is unlikely to be biliary atresia. What are the indications for liver transplantation in biliary atresia?
End-stage liver disease.
Failed Kasai. You are rightly mentioned. This is a child with one of our patients with end-stage liver disease, failed Kasai and end-stage liver disease, recurrent severe cholangitis, poorly controlled GI bleed due to portal hypertension, intractable ascites, not responding to any sort of treatment. These are some of the indications for liver transplantation in a child with biliary atresia. Post-Kasai children. This is one of my patients. Is a 14-year-old child post-Kasai, but unfortunately she has recently decompensated. This is another 5-year boy post-Kasai, 5 years. He's doing well. What are the cardiovascular lesions of Allergen syndrome? What is the most common lesion?
Peripheral pulmonary artery stenosis.
Peripheral pulmonary stenosis is the most common lesion, but there can be pathology of fallow, pulmonary atresia, VST, AST, all these conditions can be there. Okay, the most common one is peripheral pulmonary stenosis followed by pathology of fallow. This is the liver biopsy finding in biliary atresia. The portal tracts will be expanded. Classic finding is bile ductal proliferation, edema of the portal tract, then there will be fibrosis and some amount of inflammation. Another finding is bile duct flux, bile duct, canalicular and bile ductal bile flux. So this is another very classic lesion of biliary atresia in liver biopsy. How will you prevent? One of the serious complications of Kasai's operation is recurrent cholangitis. Why? Because you are connecting the blood in the liver to the contents of the gut. It's very easy for cholangitis. How will you prevent that?
Antibiotic,
Antibiotic. Which antibiotic? Latest antibiotics. Latest trimethoprim. Or you can try Neonatal. These are the antibiotics which have been tried all over the world to prevent recurrent cholangitis. Trimethoprim, that is cotrimazole, Septran or Neomycin. What's the most important biochemical investigation when alkaline phosphatase is very high? Next investigation is the
GGT.
You always do it. It's a very extremely useful investigation will be GGT. Name the neonatal cholestasis syndrome with normal or low GGT.
PFIC.
Allah PFIC except PFIC3. Bakilla PFIC. Then agonist syndrome, ARC, bile acid synthetic disorders, Citrine Deficiency, BRIC, benign recurrent hepatic cholestasis. There are several conditions, or not several conditions, a few conditions in which GGT will be low or normal. You expect the GGT to be equally high as the alkaline phosphatase. There are a few conditions in which the GGT may be either normal or low. That is the importance of GGT, because you can pick up these conditions and can do specific tests for these conditions. Role of USG. You are the pediatrician. You are the resident pediatrician. What precaution will you take when sending a child for ultrasonography? Ultrasonography
fasting.
Etra manikkur fasting
4 hours.
At least 4 hour fasting. Appo kutti karne endu 4 hour
glucose water.
Glucose water vani kodukka. Sick kutti ani IV fluid kodukka. Otherwise, if you give breast milk, gallbladder will be contracted.
Right.
And the presence of a distended gallbladder is a strong point against biliary atresia. If the gallbladder is distended, that is a very strong point against biliary atresia. But there are some types of biliary atresia, rarely, in which gallbladder may be present. But usually that's the point against. You can observe whether the gallbladder is contracted. Functional gallbladder will contract when the mother feeds the baby. Then you can diagnose choledochal cyst. You can diagnose choledochal or condition IB, inspissated bile duct syndrome can also be diagnosed by US. It's a very simple investigation, in non-invasive investigation, cheap also, freely available. Then you can look for polysplenia, asplenia, situs inversus, which all these may be a part of BUSSAM. What is BUSSAM? Splenic malformation. You can look up all these things. Due to the lack of time. Darli time I can always stop at any time. I can stop.
This is unlimited Zoom. Okay.
When you feel bored, you can just tell me.
It's being recorded.
Okay. So what is this?
Triangular cord cell.
Very good. This is a triangular chord sign. What is triangular chord sign? Example, what is triangular chord sign? This is the triangular chord of echogenicity. This is the triangular chord of echogenicity of the anterior wall of the right portal vein, 4 millimeter wide and 16 millimeter long. So this is the triangular chord. So this can be picked up only by experienced radiologists. Due to fibrosis of tissue in front of the portal structures. What is gallbladder ghost triad? Gallbladder ghost triad. The gallbladder looks like a ghost of the normal gallbladder. This is the normal healthy gallbladder. This is the gallbladder ghost triad. And the ghost madrilla. The contour is irregular and the lining and wall are indistinct. So this is the triad. Gallbladder ghost triad. Short ana, irregular and relatively indistinct lining and wall. What are the prognostic factors of Allergen syndrome? Suppose you've got a patient with Allergen syndrome, which comes as a DD of biliary atresia. You do a serum bilirubin and cholesterol level. If the serum bilirubin is more than 6.5 and cholesterol is more than 520, these are very bad prognostic factors of Allergen syndrome. Right. Now, what is this?
Sando.
Yes, yeah.
Sando.
These are extensive xanthoma. One of my patients with Allergen syndrome, see, xanthoma, her serum cholesterol is more than 1000 milligram per cent. What is the typical histopathology finding of a xanthoma? If you do a biopsy, what would you find? Vishnu or anybody in the chat box? Yes.
Cholesterol giant cells.
And a parent.
Two-tone giant cells.
Very good. That is two-tone giant cells.
Musa has written.
Okay, Musa. Two-tone giant cells. Two-tone giant cells in Allergen syndrome. Okay, what is this?
Allergic facies.
Typical faces are like a broad forehead, triangular face, pointed. Can you see the pointed chin?
Yes.
Even the deep set eyes. Deep set. Look at the nose, bulbous tip. At 10 months, he could repair Vishnu incidentally. 4 years because the faces has changed. And this was taken, unfortunately, he comments that this was taken a few weeks before he died. What the finding in his mouth? A very classic finding in the mouth of this, sir. What is that? Vishnu? Anybody in the chat box?
Achilles has written chlorodentia.
Chlorodentia. Okay, that is chlorodentia. Green teeth, which means that the dent has been exposed to bilirubin right from birth. That's chlorodentia. Pachapallu. Now, another of my patients with Allergen syndrome, he has got a tetralogy fellow. His name was Arjun. See, at 1 year, at 3 years, 3 years the face, see, typical face. He has got tetralogy. Can you see the cyanosis, central cyanosis at 5 years, 7 years, 10 years, 11 years? You can see the clubbing and cyanosis. So this is I saw him just a few months back. Hospital and this is the Arjun, how Arjun looks at 13 years. This is another patient who came from Kasaragod. He's got Allergen syndrome with DORB. DORB has not been described so far. Okay, Allergen syndrome with DORB. And this is again Arjun. You can see the striking similarity. Could tell face similarity.
Yes.
Both the cyanotic arteries, face is so similar. Another older patient with Allergen syndrome. What are the findings? The findings
Corneal
xanthelasma. Can you see the xanthelasma?
Yes.
This is xanthelasma, and this is anterior staphyloma due to uncorrected hypovitamin A. Unfortunately, he died a few months back. He was Dheeresh. He was doing very well. From 7 years, I have followed up to 17 years. He was lost for follow-up. Now, sometimes it will be very difficult to differentiate biliary atresia. There's so many common factors. For example, the gallbladder may be atretic not only in biliary atresia, sometimes in Allergen syndrome also. Congenital heart disease may be seen in 10% of biliary. We've already seen that embryonal type of biliary atresia. And GGT will be very high in both. Okay. So there are so many common findings between biliary atresia and Allergen syndrome. What are the genetic defects of Allergen syndrome?
JAG1 and Notch.
Mutation of JAG1 in 90% and Notch 2 in 10%. Now, what is the latest drug for interactive pruritus of Allergen syndrome? Now, what substances can be absorbed from the terminal ileum? Chat box. There are two substances which can be absorbed only from the terminal ileum. What are they? Chat box. There are two substances which can be absorbed only from the terminal ileum. What are they?
Chat box ഒന്നും ഇല്ല sir.
Again?
Nothing is there in chat box.
Very interesting. Vishnu?
Bile salt.
Bile salt. Number one is bile salt. Second one is?
Vitamin B12.
Very good. Vitamin B12. Vitamin B12 is absorbed only from the. Why is it so? Why is vitamin B12 absorbed only from the terminal ileum?
Receptors are present.
What is the name? What is the name of the receptor? Yes, you are almost it. Starts with C and M. Cubam receptor. Cubam receptor. Suppose the patient does not have Cuban receptor. What is the syndrome called? Cuban receptor lengal megaloblastic anemia. A syndrome the parenda. Given in Nelson. Vishnu? Yeah, you are Emerson. Very good. I think Vishnu is almost like a walking Nelson. Emerson-Grasbeck syndrome. Emerson-Grasbeck syndrome. Now come back to this. Bile salts are also absorbed from the terminal ileum. Again, absorb and there's the transport. Transport is called. What is the name of the transporter? It's called ASBT. That is called ASBT. Apical sodium-dependent bile acid transporter. Can you see that this is the transporter? Okay. Apical sodium-dependent bile acid transporter, ASBT. There are two drugs which can inhibit this drug, which are introduced in 2020 in US. What is the drug? You're almost right. Yeah.
Maralixibat.
Very good. Maralixibat. One more. One is Maralixibat. Odivixibat. So these are the latest drugs. Bangor expensive. It will be costing 5,000 or 10,000 rupees. It's extremely expensive. Our patients cannot afford it. So anyhow, postgraduates should realize that there are certain drugs which can inhibit, and this will be extremely useful in some of these conditions, especially the intractable pruritus of Allergen syndrome. What are the recent advances for the diagnosis of biliary atresia? Elevated serum levels of interleukin matrix metalloproteinase 7, MMP7. Name the latest drug being tried in biliary atresia. Latest
IVIG.
Right, high dose IVIG. What is the latest bile acid sequester? Cholesterol in the Chatanarana. Yeah, you said it. Cholesterol hydrochloride. You said other Navarna. Cholesterol hydrochloride. This is the latest drug. Cholesterol hydrochloride. Vishnu, it's very difficult for us for pediatrician to treat children of other kuttiyalne treat cheyan bhayangara buddhimundu. Ettavum buddhimulla kuttiyal aarana?
Teachers and doctors.
Teachers, pinna nurses, pinna doctors. This incident, this is one of my PGs, Neetu, who has just passed at DNB. Neetu John. So it's very difficult to treat children of teachers, nurses, and doctors in that order. This child was brought to us with only child after 15 years of marriage, with persistently pale stools, eye-colored urine since birth, only child after 15 years of marriage, and both parents were teachers. So what are the findings? You can see that he has got dextrocardia with situs inversus. Okay. Ultrasound liver is on the left side, and you can see polysplenia on the right side. Meprofen scan it is suggestive biliary atresia. This happened 25 years back. So this is a BASM, biliary atresia splenic malformation syndrome. And we did an laparotomy. What is the finding in the liver? The liver is already cirrhotic.
Cirrhosis.
What is this? Our surgeon has already has done a Kasai's operation, but it is very late. And the long fingers belong to a tall surgeon, was Dr. Patani's classmate. Dr. Joseph Patani's classmate. This was actually done by Akbar Sharif. Tall surgeon.
Sharif sir, Akbar Sharif.
Yeah, he was a tall surgeon. Okay, this surgery was actually done by Dr. Akbar Sharif, but unfortunately, it was very late. This was what happened. It happened. He developed. He tried in the photo. like you develop all possible non-complications of biliary atresia, and you also died. So what are the second line investigations? The first line investigation, you do the second line investigation. The initial workup is inconclusive. You can do a TOR screen, succinyl acetone, type 1 tyrosinemia, gall workup, cystic fibrosis workup, serum cortisol, and what is jaundice chip? Heard of that? Jaundice chip. Heard of that? Jaundice chip. What is
genetic test?
The chip-based genetic sequencing of for inherited intrahepatic cholestasis. JAG1 കണ്ടുപിടിക്കാൻ പറ്റും, LTPB1, that is PFIC1, എല്ലാ PFIC-ഉം കണ്ടുപിടിക്കാൻ പറ്റും കേട്ടോ. ABCB4. So this is Serpina1 is for alpha 1. So that is jaundice chip. Now we'll go to the revision questions. I think try to finish it as early as possible. Are you all hungry, Vishnu? You're hungry?
No, sir.
Can I continue for some more? Continue with Dr.
Yes,
Carl?
yes.
Yes, sir. Yes, sir. Yes, sir.
Yes, sir.
Okay. What is the most important clue to the diagnosis of neonatal cholestasis? The most important clue to the diagnosis of not only neonatal cholestasis, any disease is suspicion. Just like this classic Alfred Hitchcock thriller, Suspicion, starring Cary Grant and John Fenton. Suspicion is very important. You should not feel that, oh, this is only biliary atresia. This may be this may not be biliary atresia. It may be Allergen syndrome. This may be anything. So you should always suspect other conditions. So how do you approach a child with jaundice? First is history. What is second, Vishnu? History.
Urine color.
No, I will always take history. I will return history 3 times. I just want to underscore the importance of taking a proper history. Because if you do not take a proper history, but if you do not take a proper history, you'll miss the diagnosis. Then you examine the child proper history and do the relevant investigation. So we should be like whom?
Sherlock.
Not only pediatricians, but all residents, all doctors. I believe that all doctors should be like Sherlock Holmes. Scleral ictus or conjunctiva, which is correct? Correct.
Conjunctiva.
Who is this?
William Osler.
William Osler. Sir, William Osler had defined the jaundice as yellow tinting of skin and conjunctiva, not sclera. If you search the internet, you will see lots of articles saying that it is conjunctivitis and not scleral. Lots of it. The correct is actually conjunctivitis. Because now we know that what is the blood supply of the sclera?
Avascular.
The blood cells sclerae are avascular, so bilirubin cannot be transferred to the sclerae. Actually, bilirubin is deposited in the bulbar conjunctiva or like the sclera. So correct terminology is conjunctival ictus and not scleral ictus. I think we will skip some slides. Wow, when should a child with suspected cholestasis be referred to the pediatric action? That's a very good question for you. All babies with cholestasis are more than 2 weeks for which no identifiable cause can be found. Suppose that we're not able to find out a cause, even after 2 weeks of evaluation, then he may be referred. History of sibling death due to undiagnosed cholestatic liver disease, that may be an indication. If the child occur features hepatic failure. These are some of the indications. Is hyperbilirubinemia ever beneficial to the neonate, Vishnu? Is it beneficial? Is it ever beneficial to the neonate? Yes, because the unconjugated bilirubin has potent antioxidant and free radical scavenging properties. It's a very powerful antioxidant. So these may protect cells that are exposed to high levels of oxygen at birth. Now, what should a pediatrician do as soon as they see a baby with cholestasis? Suppose you are working in the periphery of Kerala, village, you are seeing a 1-month-old baby with a cholestasis. What should you do first? Vishnu, what will you do?
Vitamin K injection.
Very good. Always give a shot of vitamin K because he may be deficient in vitamin K that can cause intracranial hemorrhage. Which antibody should be avoided? Ceftriaxone. What is the most important clinical examination? What is the most important clinical examination in neonatal cholestatic disease in the periphery?
Stool culture.
Oh, that's right. Visual examination of stool for 3 days. This is one of my patients who was admitted yesterday. Okay, pale stools. This is the golden normal stools, pale stools, another child with pale stools. DD of a sick child, we already parnayana, type 1 tyrosinemia. So these are revision questions for you. Name the cholestatic syndrome with a relatively good prognosis. The choice is cholestatic syndrome with a relatively good prognosis.
Sepsis.
Agonist syndrome has got a very good prognosis. Citrine deficiency has got a good prognosis. BRIC, and the parent BRIC, benign recurrent hepatic cholestasis or Summersmith syndrome. And most of the inborn errors of bile acid synthesis, they have got a relatively good prognosis compared to the others. What the diagnostic value of serum lactate? Serum lactate, mitochondrial hepatopathy and citrine deficiency. Mitochondrial hepatopathy and citrine deficiency, serum lactate may be increased. The screening test for type 1 tyrosinemia already parnana, very high level screening test, very high level of alpha beta protein, maybe in lakhs. Which starts hepatitis is the most serious?
Herpes hepatitis.
Herpes, very good. Why? Because it causes not only hepatitis, hepatitis, encephalitis, pneumonitis, three problems. And these children should be urgently treated with acyclovir. Name the neonatal cholestasis with fulminant hepatitis failure at birth.
Yeah.
Then type 1 tyrosinemia, HLH, herpes. All this can present with fulminant hepatic failure at birth. What is this?
Choledocyst.
What is the typical triad of choledocyst?
Right upper quadrant pain, jaundice.
Pain, right hypochondrial mass. Very good. What is this?
Butterfly.
Butterfly vertebrae. This is the clue for that. Butterfly vertebrae of which condition, Vishnu?
Allergen.
Like syndrome. When was the Carrier's procedure introduced? 1959. 1959. Which test helps to predict survival following Kasai? Serum bilirubin. If the serum conjugated bilirubin less than 2 mg/cent, 3 months after Kasai's operation, that's a very good prognosis. So 3 months with the serum bilirubin less than 2 mg, that is the patient is almost anictic. That is a good criteria. Recent advances. This is already universal screening, and this is the chart introduced by one of the best periodic gastroenterologists of our country, Professor Acha from Lucknow. This is Acha's integrated neonatal cholestasis card. What is the advantage? Taiwan card is stool color. He has added color of the normal. These are normal urine as well as the high colored urine. So this will be very useful to find out, to pick up children with cholestasis. Not only biliary atresia, but other causes of cholestasis also. Latest drugs. What are the drugs? Vishnu?
Maralixibat.
Maralixibat and
Odevixibat.
Tongue twister, but these are the drugs. Recent advance, elevated serum levels of interleukin 3 and MMP. What are the indications for liver transplantation biliary atresia? Pale Kasai, end-stage liver disease, progressive cholestasis, recurrent cholangitis, polychondropolar hypertension, intractable ascites. Now, what is this? This is Vishnu Ariyata. Anybody in the chat box? The radiology finding for sick-looking neonate with cholestasis and malabsorption. Can you spot the diagnosis? Sick-looking and cholestasis in the malabsorption. Anybody in the chat box?
Wallman. Achille Acetone Wallman. Wallman.
Pinarana?
Achillum Ahmad Mose.
Very good. This is in the, you can see the calcification. Vishnu is already caught it. Yes. Vishnu, this is the bilateral adrenal calcification. You had mentioned about the bilateral adrenal calcification. Wallman's disease. No pruritus. Name the neonatal cholestasis with the minimal or no pruritus. Oh, very good. Bile acid synthetic disorders, no pruritus. Treatment is the primary bile acids like cholic acid and not with orthodeoxycholic acid. What is the relevance of this bird in neonatal cholestasis?
CMV inclusion outside.
What is this word? This is the typical urine CMV inclusions are typical all-eyed inclusions in CMV hepatitis. Okay. Which simple non-genetic investigation helps to diagnose GALT?
Lip biopsy.
Lip biopsy. Lip biopsy. Lower lip biopsy, minor salivary glands will be full of hemocentrin accumulation. Will be filled with hemocentrin. So this is a very simple investigation. Which cholestatic disease presents with a painful crisis resembling porphyria? Anybody? Which cholestatic disease presents with painful crisis that resembles porphyria? That is type 1 tyrosinemia. Okay. How will you diagnose it? I'm going to succinyl acetone. This you can look up later. You know that succinyl acetone will inhibit the porphyrin metabolism like this. Porphyrin synthase will be inhibited by succinyl acetone. That's the reason why you get porphyrin-like symptoms in type 1 tyrosinemia. You can see that. Kananda, Vishnu?
Yes, sir.
Okay. How does cholestatic liver disease cause rickets?
Malabsorption of vitamin.
First of all, their diet will be poor in vitamin D. Deficiency of bile salts decrease vitamin D absorption. Steatorrhea absorbs vitamin D absorption. Cholesterol therapy aggravates it. And these children do not go out and play. These are some of the important causes of rickets. Then the damaged liver is not able to 25-hydroxylate vitamin D. These are some of the causes and the mechanism why rickets is called hepatic rickets. What are the causes of bite out spots in liver disease? Cholestatic jaundice and decompensated chronic liver disease. Retinol binding protein, that is the transport protein of vitamin A that cannot be synthesized. So metabolism of vitamin A will be inhibited. The anorexia, they will not be taking vitamin rich food also. Where is vitamin A stored in the liver? Vishnu? Where is vitamin A stored in the liver? Stored in the Ito cells in the space of this. Ito cell has two functions. One is to store vitamin A. The second is to synthesize collagen. So when cirrhosis, Ito cells start synthesizing more and more collagen, and so they are not able to store vitamin A. So that's the second reason why in cirrhosis, vitamin A metabolism is affected, because the Ito cells are not able to store vitamin A now. This is a classic liver biopsy finding of a genetic disorder which causes cholestasis. What is that? This is the PS positive, diastase resistant, magenta colored globular inclusions of endoplasmic reticulum periportal hepatocyte. What's the diagnosis, Vishnu?
Alpha-1
Very good. This is alpha-1 antitrypsin deficiency. What is the mechanism of liver injury in alpha-1 antitrypsin deficiency?
There is the tertiary structure of protein is not formed, so accumulation in the endoplasmic reticulum.
Absolutely, very good. The abnormal alpha-1 antitrypsin cannot be transported out of the liver. It accumulates in the hepatocytes and subsequently causes damage. Okay. Liver biopsy is dangerous in which neonatal cholestasis syndrome? One is ARC syndrome. The second one is type 1 tyrosinemia. Both may be associated with severe coagulopathy. A baby with cholestasis is a very low serum cholesterol. What's the diagnosis? Smith-Lemli-Opitz syndrome. Very good. Now, what is the treatment for Smith-Lemli-Opitz syndrome? Egg yolk therapy. 2-year-old girl born to consanguineous parents with FTT, C-stasis, and cholestasis. What could be the diagnosis?
Niemann-Pick.
The Niemann-Pick cells are concerned. This is Niemann-Pick. Why are medium chain triglycerides better absorbed in the presence of cholestasis compared to long chain triglycerides? This may be asked in the examination.
Direct absorption.
One is medium chain triglycerides relatively more water soluble compared to long chain fatty acids. One reason. They do not require bile acid for their absorption. It's very important. They do not require bile acid. They are absorbed directly into the portal circulation, unlike long chain fatty acids, which are absorbed in the lymphatics. And the fourth one is the more important one, is they can reach the mitochondria for beta oxidation even without carnitine. Whereas long chain fatty acids can be transported to they can reach the mitochondria only with carnitine. Carnitine less than they can reach the mitochondria. It's the most severe form of PFIC.
PFIC2, sir.
PFIC2 is the most severe. Latest drugs called Sivalam, other Vishnu has already mentioned. In which cholestatic liver disease is liver transplantation contraindicated? Zellweger, very good. Then HLH and SL. All these are multi-system diseases. Zellweger, HLH, and Smith-Lemli-Opitz syndrome. What are the causes? Some of the last slides. What are the causes of delayed referral neonatal cholestasis. In the most of the doctors will be misdiagnosing physiologic jaundice or cholestatic jaundice and physiologic jaundice. Manjapathan or physiologic jaundice, so improper follow-up. Ignore the mother's complaint that the urine is high colored. You should never ever ignore the mother's complaint. Mother parayana doctor Mutra Manya, you have to believe that. Physiologic diuresis physiologic diuresis down. So what will happen? The urine color will be decreased. And many people still fond of heliotherapy and Pandora drug and Dr. Darley will be remembering Leaf 52. Leaf 52 it's a panacea, Ottamulian Leaf 52. Okay. So babies with conjugated hypertension should be referred urgently. The child with cholestatic liver disease, if you do not think about it, you won't look for it. If you don't look for it, you won't find it. And if you don't find it, you can't treat it. And this is the nutshell cholestatic liver disease. And if you cannot treat it, you can't save the baby. So a pediatrician who is not aware of the importance of cholestatic jaundice, a pediatrician who is not aware of the cholestatic, so what happened with your child? When they adopts the weight, I think this baby, this policy was adopted, like wait and watch policy, tries non-specific drugs, refers quite late. He was referred only very recently, so the baby will be critically ill. Surgery will not be possible in such a late stage. So this is called the road roller pace. Road roller this is called a road roller pace investigation. But thanks to NNF, IAP, and pediatric gastroenterologists, this is not happening now. Now pediatricians are, because the people like you are more and more aware of the importance of early referral. Thanks to the efforts of IAP, NNF, and so we are adopting what is called the fire brigade pace. This is called the fire brigade pace. Now, finally, you should always believe the mother who is worried. She is likely to be correct. Mother parent doctor Kutida Mutram, Kandla Manyarunda, Ali Mutratil, and then Manyarik. I mean, the white upon the Kotsivella, Narthan, the parent, you should, if the mother is worried, you should also be worried because the mother is always likely to be correct. Similarly, Pandamala for all that visa is not asthma. Similarly, all neonatal cholestasis may not be biliary, maybe several other things also. So finally, the take-home messages are conjugated jaundice is always abnormal. Always rule out biliary atresia in neonatal cholestasis. Identify treatable cause of cholestasis. I have already stressed the role of GGT in the evaluation of childhood cholestasis. And the role of vitamin K. At diagnosis, you have to give a shot of vitamin K, which can prevent, which may sometimes even prevent fatal intracranial hemorrhage. Now, how should pediatrician tackle neonatal cholestasis? A lighter answer. Don't take it very seriously. Vishnu, can you see this?
Yes, sir.
So, pediatrician should be aggressive when tackling cholestasis. This photo is now, European pediatrics are actually more aggressive. Who are the most aggressive people in the world? The Americans. Let's see how American pediatricians tackle. Extremely aggressive. Aggression, but how we used to tackle, past tense, how we used to tackle cholestasis. The Indian style, non-violent. Normally, we are fond of non-violent. So we give a heliotherapy, non-specific drugs like Leaf 52. We never make a diagnosis of biliary atresia and the child dies of his own without a diagnosis. This should never happen. So thank you so much. So what is the verdict? The verdict is that I'm really, Dr. Darley, I'm really impressed with your postgrad, Vishnu. Extremely good. The verdict he has passed with flying colors, and I'm sure that he will make a great pediatric gastroenterologist of Kerala.
Thank you, sir.
Thank you. Thank you, sir. Thank you.
Thank you, sir. Full credit is for Vishnu only. Yeah. He only has prepared all these things. I can just point out this case to you, to him. That is all what I have done. Yeah. And also Suresh has also same thing. In three of us are in the same unit. Just point out the case.
A large chunk of the recruit definitely goes to all the teachers. Please give them a big hand, all the teachers of Vishnu.
Thank you, sir. Thank you for that wonderful class.
Thank you, sir.
So it was a 2-hour thing. Everything about cholestasis has been mentioned in that class, and it's very, very high time we had a class like this from Doyens as Riaz sir. So I think Shanavas sir is here. Sir, can you make a Shanavas sir?
Okay. Good evening to all. It was a wonderful class. Both the presenter and the chair were wonderfully led the topic, and it was a 2.5, nearly 2 hours, 15 minutes time with the knowledge that is flowing from the source. So thank you very much, sir. Thank you very much. Thanks to Riaz sir and the presenter and both Dr. Darley and Dr.
Thank you.
For the.
Thank you so much, Dr. Shanavas. Thank you so much.
Yes, sir, it was a wonderful talk. First of all, in 1981, my short case was only congenital biliary atresia. The doctor, the examiner from Chandler asked me, what is your diagnosis? I said, congenital biliary atresia. He asked only one more question. What is Kasai operation? If you had asked another question, I would have been failed. Actually, today I feel that you would have been there to have a class before that. It is 41 years before. That time in Nelson, it was only written in a few sentences only, nothing else. Anyway, the credit goes to your excellent class. Vishnu also really has done very well. On behalf of IAP Kottayam as a president, I thank you very much. Vishnu also, I thank you. And Dr. Musa in his absence, he is not in the field. He has also done well. And I think those who have not seen this class or present, they lost their half of their whole life, I should say. I thank you, Dr. Riaz and Vishnu and other Raleigh Madam, Dr. Suresh. Thank you very much.
Thank you. Thank you. Thank you.
So, sir, dear Riaz sir, no words can express our thanks towards you because it was a wonderful session for all of us.
Okay.
And on behalf of IAP Kottayam, I thank you for your wonderful class this session, and always you were helpful to us because the very moment I asked you to take the session, you accepted our invitation and accepted of taking the class. So again, once again, thank you all. I also thank all the delegates for being on this session, and I am very grateful to Vishnu also for preparing the sessions in such a nice way. I also thank all the office bearers of IAP Kottayam and IAP Kerala State for giving us this opportunity for doing this session. Thank you. Thank you all once again. Have a nice night. Thank you. Good night.
Thank you.
Yes, sir. Thank you very much, sir.
Okay.